good morning, and a very warm welcome to the second annual Research Conference on Global Lead Exposure. I'm Michaela Gavas. I'm the Managing Director of CGD Europe. I'm also a Senior Fellow, and I'm delighted to see so many of you here. And to those joining us online from around the world, welcome to you too. So we've brought you all together, researchers, epidemiologists, economists, policymakers, implementers, funders. And that's because lead exposure is a health issue, it's an environment issue, it's an education issue, and it's a development issue. But before I go any further, a few important thank yous. So this conference is co-hosted with the Partnership for a Lead-Free Future. We are very grateful for their partnership and everything that they bring to this work. We also want to thank Coefficient Giving's Lead Exposure Action Fund for supporting the conference. And finally, last but not least, I would like to thank the incredible CGD team. None of this would have been possible without you. So let me say a few words about why this work matters and why it's so urgent. Lead poisoning is a solvable global problem. In most cases, we can identify the source, replace lead with safer alternatives, and reduce exposure through practical regulation and enforcement. But the scale of the problem is really staggering. Up to 815 million children worldwide are affected by lead poisoning. That's roughly 1 in 3 globally, and closer to 1 in 2 in many low and middle income countries. The WHO estimates lead causes 3.5 million cardiovascular deaths a year. And Drew McCarter from Pure Earth put it very starkly in his TED Talk that this is larger than all natural disasters, all active wars, all traffic accidents, HIV, and malaria combined. The economic cost per WHO estimates runs to around $6 trillion a year, and that's roughly 7% of global GDP. And our own CGD research suggests lead exposure may account for over 1/5 of the learning gap between rich and poor countries. So there is no safe level of lead exposure. Even relatively low levels damage learning and behavior, impairing memory, attention, and the ability to learn. It is linked to behavioral problems in childhood and to higher rates of crime in later life. For pregnant women, lead stored in bones can be released into the bloodstream and cross the placenta, meaning a mother's exposure becomes her child's present one. The damage is largely irreversible. These are stolen futures, compounded across generations. But the good news is that momentum is building fast. Since we gathered last June, Bloomberg Philanthropies has launched its lead poisoning prevention initiative. The Asian Development Bank has published an operational approach for a lead-free future across Asia and the Pacific. And the Partnership for a Lead-Free Future's one-year update shows partners working in over 55 countries. But we need to go further, and we need to go faster. So what do we hope you take away from the next 2 days? Well, 3 things. Firstly, new relationships across disciplines and institutions, because that's where ideas become action. Second, a clearer sense of the research agenda, including where exposure is coming from, how to measure it more accurately, and which interventions work best and for whom. And third, practical ideas for implementation. What governments can do next, what researchers can prioritize, and what implementers can do. The agenda over the next 2 days covers a lot of ground. Exposure sources and consumer products, surveillance, health outcomes, treatment, policymaking and environmental exposure, with new field evidence from a range of countries, We have interactive sessions on measurement tools, implementation playbooks, and the newly launched WHO Global Technical Package on lead poisoning prevention. And we close tomorrow with a panel on science-based policies for a lead-free future. So I'll now hand over to Lee, who together with Rachel Bonnefeld has really spearheaded this work at CGD. Thank you all for being here.
Thanks very much, Michaela. Welcome, everybody, on behalf of CGD and the Partnership for a Lead-Free Future. It's amazing to see so many people here. My name is Lee Crawford. I'm a senior fellow at CGD based here in London. You'll notice I'm not Rachel Bonnefeld, who a lot of you know. She's just had a baby, so I think it's a reasonable excuse to not be here. If not, she would be standing here instead of me. I was just looking back to 5 years ago, the first thing that Rachel and I and a former colleague, Susanna Hares, wrote about lead exposure. And we were aware of the issue, but we noticed the political opportunity, the moment when the American government was announcing a huge domestic program on lead exposure, billions of dollars to replace every lead pipe in the country. And we thought, you know, this is a bigger problem internationally, and the US has a big foreign assistance budget, and you should maybe put some effort into looking at the international space as well. I think that blog still holds up quite well. I don't think we quite realized how much lead was going to take over our lives when we wrote that. We work on lots of different topics at CGD. Often we'll start work on a new topic and we'll gather experts and we'll do a working group, we'll propose some new policies, and then we'll move on to the next problem. But we're still here working on lead 5 years later, and I think everything about the problem really demands attention, that it's such a big problem, as Michaela has outlined, that it's tractable. We seem to be making progress. We've made progress in the past, and we're making progress addressing it now. And still, despite the scale of the problem, it's relatively neglected relative to the scale of this issue. So it really seems like an issue still worth paying attention to, despite all the great momentum we've had in the last couple of years. So why this conference? I think one of the exciting things as a researcher about lead is that it's so interdisciplinary. So I came to it from the research from economists, but obviously a lot of the research has been done by doctors and epidemiologists and scientists. But that's meant the field has been somewhat siloed into these separate disciplinary conferences. And it's kind of crazy that there hasn't been a global lead conference before. There's a global lead conference on malaria, on HIV, on tobacco, on all the big health risks. And so we felt that it was important to convene you all here for this conference and to try and create these new connections and collaborations. At CGD, I think our role covers 3 areas. 1 is doing new research ourselves. 2 is helping to aggregate and amplify all of your research. And 3 is talking to policymakers and trying to, the people in Washington, DC and in London and Europe, and trying to get all of that information into action. I'm really proud of some of the research we've done over the last 5 years, covering the range of themes that we'll cover at the topic. So starting with outlining just how big of a problem lead is for education and learning in developing countries, moving on to looking at the big sources of lead exposure, and we did some new research showing how big of a problem battery recycling is. We think about 1/3 of the burden coming from battery recycling. Recently, we just published a new systematic review on iron and calcium supplements, which help a little, but clearly don't solve the problem. And then some of the work we've been doing recently focusing exactly on these policymakers who can make a difference and scrutinizing some of the World Bank's portfolio and their investments in energy and in water and whether there are lead risks coming from that. And those are kind of the themes of the conference and the research that we've been trying to support, which is around looking at the impact of lead. We know it's a problem. We're not trying to relitigate that, but exactly how big of a problem it is, what the big sources are of exposure, and then what can we actually do about it, and what are people doing, and what's working. What's new this year? This is our 2nd conference. We've had an increase in submissions. We had about 100 submissions last year. We had about 150 this year. So it's exciting to see this growth. I think there's a lot of exciting work in the pipeline, work that Coefficient Giving are funding, and many others are funding. So there's tons of exciting stuff entering the field now. So hopefully next year we're going to have an even bigger conference. CGD has been funding some research ourselves directly. We launched an RFP with Coefficient Giving's funding a couple of years ago. we gave out $1 million to 9 projects. We had many more excellent proposals that we couldn't fund, and so I'm really excited to announce that we're going to be launching a second RFP up to $5 million. That's on our website now, so you can take a look at that. If you're a researcher looking for funding for your next idea, I encourage you to take a look at that and apply. The deadline is in 2 months from now on the 2nd of August, and we've designed it to be as light touch as possible, so we hope it's not a huge burden. The themes for the conference, as I've said, are looking at sources of exposure and then policy interventions to reduce lead exposure. We have 40 speakers from 14 different countries over the 2 days. We also have some interactive sessions with some lead testing devices that you're going to get to play with. I'm hoping to get my first blood lead test, if that's a possibility. Today, we have a first panel on different sources of lead exposure, including food, cosmetics, different consumer products, and lead battery recycling. Then we have our interactive sessions on blood lead surveillance. After lunch, we have a panel on large-scale representative household surveys, which are really important, including the first national blood lead surveys from Bhutan, Bangladesh, and Kyrgyzstan, as well as representative surveys on contaminated spice consumption in India, which is a potentially really important problem. And then our final panel will be on health outcomes and treatment, including the first new oral chelating agent for lead in decades. So I hope you managed to learn something from these 2 days. I hope you managed to speak to some new people. If you're new to our community, I encourage you to subscribe to our newsletter. You can find these postcards outside with a QR code. We also organize a monthly online meeting, which has close to 100 people attending every month. So I encourage you to engage. If you're a funder or policymaker, our final panel tomorrow will include representatives from 4 different governments, Brazil, Ghana, Pakistan, and Vietnam. So I hope you stick around for that. And tell us what we're missing. So the agenda is all of ours to shape. So come and talk to me or anyone else from the CGD team, and we'd love to hear your feedback. Our keynote speaker was supposed to be here, Phyllis Amido. Unfortunately, in their wisdom, the British Home Office didn't manage to get her a visa in time, but she's recorded a video message for us. So apologies on behalf of our government for that failure. Phyllis is a widely respected Kenyan environmental activist whose work is really why we're all here. She took a job herself in a lead-acid battery smelting plant in Mombasa, only to discover that the plant was poisoning her own infant son, along with thousands of people in her community. And when the plant and the local government ignored her complaints, she mobilized the community at great personal cost. She was attacked and arrested, but ultimately went to court and won a landmark $12 million compensation for her community, and went on to found the Center for Justice, Governance, and Environmental Action, as well as winning multiple international environmental awards. She's been referred to as the East African Erin Brockovich. So hopefully we'll get a movie about Phyllis soon. But in the meantime, please join me in welcoming Phyllis Amido. Thank you.
Good morning, ladies and gentlemen. My sincere apologies that I was not able to make it to London for this very important conference. We had some Global South issues and we were not able to access our visas on time. Actually, they've not yet been sent, so my most sincere apologies. Today, I would like to talk but also share my experience as a grassroots environmental rights defender from the Global South. Foremost is how do I define lead poisoning and lead pollution as a grassroots frontline defender from the Global South. I would say highs and lows, optimism and despair, hope and deep discouragement. These are the realities that have shaped my 10 years of advocacy for a lead-free Kenya. In that time, I have met some of the most phenomenal human beings on the planet. In my first few years, I met Sami, a little boy, about 2.5 or 3 years old, just learning to talk. And I greeted him, a Kenyan greeting that translates to, "How are your loved ones, Sammy?" And he told me, "I love you only, Phyllis." Of course, he stole my heart. And I was determined that Sammy would not live under the scourge of lead poisoning. Unfortunately, with over 100 micrograms per deciliter of lead in blood, Sammy succumbed to lead poisoning around 2016 or 2017. I met Lynette Nabwire.
Cowards, they suffer a lot, but they live long. Sasa hiyo msemo huwa nachukulia kweli sisi maskini tunahangaika sana na hii shida zetu za chini chini.
Last January, we spoke to Lynette Ouma, a resident of Owino Uhuru slum in Mombasa, a place whose residents have been falling ill and dying from lead poisoning, with the county and national government's full knowledge. She had fallen victim to the effects of lead poisoning already, having miscarried twice in 2 years. Miscarriages are common amongst women with elevated blood lead levels. Lynette's enduring wish was to have a baby.
And that we needed the ear of the president on this.
1 year after meeting Lynette, we've gone back to Owino Uhuru to check on her and everyone else.
Lynette, a young wife just married, determined to hold up the culture of the African people by getting children for her family. Unfortunately, Lynette had more than 280 micrograms per deciliter of lead in blood. She had had more than 4 miscarriages. Eventually, we managed to remove the source of pollution for their community, which was a lead smelter, in 2014. And Lynette was able to carry her baby to term up to 2015. Unfortunately, a few days later after childbirth, Lynette succumbed because her lead levels were too high. Irene Akinyi, young mother also, 420 micrograms per deciliter of lead in blood. Irene is still alive, barely hanging on. Her thyroid has given up. One of her kidneys has failed. I have met scientists, researchers, philanthropists who have volunteered their time, their money, their expertise, often quietly and without recognition. Community leaders who became environmental experts out of necessity. Victims, women, children, and men who fight tooth and nail to stay alive while battling lead poisoning. A disease that most hospitals in Kenya are reluctant to address. Communities who should never have had to become experts in their own suffering. I have been privileged to lend my voice to these victims, and I'll be honest with you, there are days that I feel that I have failed them. When I count the number of lives that we have lost, the funerals that I've attended, the children who sadly never reached adulthood, a Kenya that carries a disproportionate burden of lead as the more developed nations reduce their heavy metal burden. How should we all reconcile the concept of civilization and morality with the reality of the burden forced upon the weakest among us? But then I remember those who are still here, still organizing, still documenting, still demanding justice. And today I address a room full of experts, policymakers, funders, and advocates who have the capacity to restore the right to a clean and healthy environment and the right to health for all people, regardless of where they are born. It is said that there is more hope for a living dog than a dead lion. This proverb reminds me that as long as we are alive, there is hope. As long as communities are still fighting, as long as knowledge still exists, then surrendering is not an option. None of us has the luxury of giving up. Failure, quite simply, is not acceptable. Yet the work is not straightforward. It's often deeply confusing, especially when the truth collides with power. It's us versus corporate elite who wield unlimited resources and power, including political favor. This is about money, profit, power, and human nature operating without limits. It's about our attempt to create limits. This work is revolutionary. It's very political. Recently, Kenya's National Environmental Management Authority took me to court. Their claim is that heavy metal contamination in a community settlement polluted with toxic pollutants has self-remediated, and therefore there was no need for scientific remediation. I remember sitting there and genuinely questioning my own sanity, because Kenya's award-winning environmental agency must surely know something that scientists across the world did not discover yet. A self-remediating environment, a miracle of toxicology. I'm not sharing this story to be cynical. Far from it. I do not have the luxury being cynical. I share this story because it illustrates the reality of many in the global south. Many defenders live with this reality every day. The space where scientific evidence ends and political convenience begins. The space where denial is cheaper than action. And that space is where people are getting sick and dying. This is why your presence in this room matters, because we know how to prevent it. We know how to remediate it. We know how to regulate it. Lead poisoning persists. Lead poisoning persists because it's profitable for someone somewhere for it to persist. The idea of a lead-free planet sounds morally obvious, but in practice, it translates into decrease in profits, increase in investments, in emission control technologies, in cleaner production, in environmental monitoring, in public health systems, in enforcement. It touches taxes, it touches capital and profit margins, it touches corporate accountability, it touches political courage. And when you touch these things, you are no longer neutral. You become inconvenient in a world where capital overrides human rights. In this work, you are often labeled either villain or hero. History will decide that. But for communities living with lead poisoning, labels are irrelevant. What matters is whether their children can grow up healthy. The global lead movement is gaining momentum, particularly in the United States and in various international circles. This is very important. It's overdue, but momentum without direction can do harm. The global south does not suffer from lack of expertise. We suffer from lack of power alignment. Across Africa, Asia, and Latin America, there are researchers, clinicians, environmental lawyers, community organizers, and affected communities who understand lead exposure, not as an abstract burden of disease, but as a daily lived reality. They know where the contamination is. They know who is responsible. They know what solutions will work locally. What is often missing is not knowledge, but resources, political backing and trust. Too often, solutions are designed far from places where lead exposure occurs. Too often, funding flows around communities instead of through them. If this movement is to succeed, this must change. We need partners who are willing to invest in long-term, locally led solutions. We need international institutions willing to listen. We need to recognize that justice is not an optional or add-on to public health. It is the foundation of it. When we talk about eliminating lead exposure, we are talking about dignity. We are talking about children's futures. We are talking about whether economic development must always come at the cost of poor people's life and health. The answer must be no. So I challenge everyone in this room today, especially those who control capital, policy, and platforms, to reflect on how power is shared in this movement. Ask yourselves, who defines the problem? Who controls the resources? Who is accountable when interventions fail? If we get this right, if we truly connect global momentum with the ground leadership, we can do more than eliminate lead poisoning. We can set a precedent for how global health challenges are addressed collaboratively, equitably, and effectively. As for those of us gathered here today, one thing is clear. We have our work cut out for us, and the world is watching, not our intentions, but our actions. Let us make sure that when history looks back on this moment, it says we chose courage over convenience, partnership over power, and justice over profit. Thank you so much. Thank you for being here, and thank you for the work that we are going to do in the next days.
Is Laura Hughes here? Yes, she's at the back of the room. I'm delighted to introduce the moderator for our first panel, Laura Hughes. She's a public policy correspondent at the Financial Times and has been doing some fantastic reporting on lead exposure in the UK, which is a much less of a problem than it is in much of the global south, but it's still a real and bizarrely neglected problem here, where maybe 1 or 2% of children have lead exposure. And Laura's driven around the country finding dead cows in Welsh fields next to lead mines. And Laura rang me a couple of years ago to, we first spoke, and you were saying, am I mad? Something like, no, why is nobody talking about this? It seems like a huge deal. And I think that's exactly right. So welcome, Laura. Thank you.
Thank you. Okay, I'll introduce the first speaker here. Thank you so much for having me. As Lee mentioned, I'm somewhat obsessed with the issue of lead poisoning. And all my work really has been focused on the UK and the total lack of regulations to test, monitor, evaluate the situation we have here. And throughout my reporting, actually, it was the work that people like you were doing internationally that reassured me I wasn't mad, that this was a problem, and that there were ways to deal with it. So I am really grateful in those moments of despair that I had, that there were people like you who were working on this all around the world. This session is going to be focused on the academics and experts who have been testing all around the world and uncovering high levels of lead. And I'm going to introduce the first speakers that we have who are going to come up and talk here. And they're looking at evidence on traditional eyeliner being used in Pakistan, Morocco, and Egypt. And we've got two people coming up to present this work. We've got, God, please forgive my pronunciation, Akanaxa. Have I done that right? I'm so sorry. Please, when you come up, say your name properly. Who is a very impressive senior research manager at LEAP, where she leads the organisation's efforts to identify, design, and test high-impact strategies to eliminate lead exposure globally. And she is joined by her colleague Jake Alexander, who is a senior consultant at LEAP, and has been leading this work on exposing traditional eyeliners and testing them. And I just read here, this is absolutely extraordinary. Jake speaks Arabic, French, Russian, Hindi, Urdu, Persian, and Swahili, and is conversational in several other languages, which is completely extraordinary and very impressive. So good luck if you guys want to make your presentation.
Thank you, Laura. How do we click the slides? This is Rahmaniya. She's a woman I spoke with a few months ago in Morocco. She's in her 60s. She's holding lead sulfide. Rahmaniya plays a really important role in her community. She grinds that lead sulfide into this powder, which is known as khol, and she sells it to families across her community to be used and put on the eyes of adults and children. This is what's known as a traditional eyeliner. These are products that are used widely across the Middle East and North Africa, West and East Africa, South Asia, particularly in Muslim communities. They're known by different names. In Arabic, it's known as khol. In South Asia, it's typically known as surma. In Nigeria, it's known as tiro. And every context has a different name for it. But one thing that they all have in common is they tend to be extremely high lead. They are made from lead sulfide. It's a rock that's also known as galena. There are other kinds of traditional eyeliners that exist. You might have heard of pastes or gels or pencils. In the testing that we've done across Morocco, Egypt, Pakistan, and India, we found that it's the powders that have the highest rate of high lead, so that's what we're going to be focusing on in our presentation today.
Okay, so here's why we think eyeliners might be an important source of lead exposure. First, we went out and tested hundreds of products across 4 countries and have found lead concentrations of between 100,000 to 900,000 parts per million. For some context, the safe level in cosmetics is around 20 parts per million, so this is several orders of magnitude higher than what's safe. Second, the exposure pathway is quite direct because eyeliners are applied to children's eyes very often daily and sometimes right from a couple of days after they're born. Third, there have been individual case studies that document elevated blood lead levels in children who use eyeliners with no other known sources of lead exposure. However, there are still important gaps in our understanding. First, First, there are many different types of products and variability in the lead concentrations of products, so it's important to understand what exactly people are using. We also need to know how often they use it and at what age they start and for how long they use it. Second, lead sulfide is a type of lead that has low bioavailability, so there is uncertainty on exactly what its impact is on blood lead levels. And finally, there's been very little work in actually testing interventions to reduce lead exposure from eyeliners. Before we move forward, I want to zoom in a little bit into this relationship between traditional eyeliner use and blood lead level impacts. The existing literature gives us a very wide range of potential effects, anywhere between 2.7 to 24.7 micrograms per deciliter. But most of these studies don't report important factors such as the usage frequency. Many of them are vulnerable to confounding factors from other sources of lead exposure, and some of them are affected by selection bias as well. So that makes it hard to interpret these estimates and apply them when trying to estimate the burden across a wide population. And in particular, we feel we might be overestimating the burden in populations that use eyeliners only occasionally. So what we did is we modeled a bunch of different scenarios using biokinetic models and varied factors like the frequency of use, the age at which kids start using this, to give us 2 separate estimates for occasional use and frequent use. And we believe that these estimates are quite conservative.
So in order to understand this problem better, because really we know so little about traditional eyeliners, we recognized that it was important to break this down into what are the most important factors of what makes this dangerous for users and how could we potentially solve this problem. So what you see here are what we think are the 3 most important factors for understanding and addressing this problem. The first is prevalence. We just didn't know a few months ago how widely used these products were in the countries that we were interested in looking into this in. We also didn't know how frequently people were using it. Intuitively, if you're using it a lot, it's going to be more dangerous than if you're using it just a little bit. We also didn't know what kinds of products are people using, and we think it's really important to know, is it formal products or informal products? Is there one manufacturer making these products that we can focus our efforts on, or is it a really fragmented market? And really importantly, are there lead-free versions of these products in different countries that we could replace the high lead products with? And finally, something we recognized was really important was to understand, why are people using these products? Because if we want to change people's behaviors, we need to understand the underlying motivations guiding this. So in order to look into these questions, over the past 8 months, we've undertaken research in 4 different countries. We've spoken with over 1,400 people, including people who are selling these products, people using these products, and we've tried to go to a range of sites. We've gone to over 50 sites in these 4 countries to really capture sort of plausible cultural variation, geographic variation, and how these products are used. So what have we found? We've found top level that rates of use really differ across different countries. So I'm going to take you through what we found just so you have a sense of what this variation looks like. In Morocco, we found that a minority of households are using it frequently on their children, and it's children's use that we're most worried about because of the elevated risk of lead exposure there. And the majority of households are using it just occasionally. Occasionally means a few times a year, at most monthly, and whereas frequent is daily or weekly. But it's much more commonly used amongst adults. But then when we went to Egypt, we found that frequent use was actually much more common on children, so 31%, but adult use was less. So really getting granular on who's using it and how often they're using it has been really important for our burden estimation that we'll get to in a second. In Pakistan, we did qualitative interviews across Punjab and Sindh, two of the largest provinces in Pakistan, to understand what rates look like there. And we found that actually frequent use of eyeliner on children is most widespread in Pakistan compared to any of the other contexts we've looked at, and that applies to adults' use as well. And finally, we've gone to India to understand what use looks like there. We've gone to 6 states. India is a massive country. We haven't yet been able to go everywhere. What we've found so far is 16% of households we spoke to are using surma, high-lead surma on children. We focused in India on districts with large Muslim populations because we hypothesized that's where surma use would be highest. We recognize that the national prevalence is likely to be lower than this, but it shows that there are pockets of frequent and occasional use of surma on children across India.
Okay, so now that we have all of this rich data, we use that to model what the potential burden of lead exposure from traditional eyeliners might be across countries. Specifically, we model the cumulative blood lead level impact, which means the total increase in blood lead levels across all children born in a single birth year. We use the 2 BLL estimates that I spoke about earlier, so applying different rates for occasional users and frequent users. And here's what we see. We see substantial variation between countries. So taking Morocco as an example, it's a relatively small population country with very large proportions of the population only using eyeliners occasionally. And consequently, the cumulative BLL impact is relatively small at about 0.4 million per birth cohort. On the other hand, a country like Pakistan with a much greater population and a much higher percentage of people who use it frequently has a cumulative BLL impact of 10.6 micrograms per deciliter. We also translated this into what the IQ points lost per birth cohort would be, assuming a half IQ point lost per 1 microgram per deciliter increase in blood lead levels, and you see similar variations across countries.
So at the same time as getting an understanding of how widely these products are used, we needed to understand, well, what are the products that people are actually using? So I'm going to walk you through what this graph shows. On the x-axis, we have on the left fully informal products, so people using products made at home. On the right, we have fully formal products, so products made by manufacturers. On the y-axis, at the top, there's just one dominant manufacturer in the country versus many small producers at the bottom. And in the different colors, we have the availability and uptake of lead-free substitutes. So green means there are lead-free substitutes, people are using them. Orange yellow means there are lead-free substitutes, but they're not being used very much. And red means there are no lead-free substitutes being used barely by anyone at all. And so what have we found in the sort of diversity we see in markets and countries? In Morocco, it is essentially the vast majority of people are using fully informal products made from that lead sulfide rock I showed you the picture of earlier. These are extremely high lead. They're typically above 300,000 parts per million. So this is many, many, many times the safe limit, which is 20 parts per million. In Pakistan, on the other hand, it's a much more formal market. So as you move along the x-axis, and there's one dominant manufacturer that we estimate takes up around 50% of market share. That dominant manufacturer also makes extremely high lead products. So typically between 200,000 and 900,000 parts per million. So insanely worrying levels of lead. In Egypt and India, we see that there are actually more lead-free substitutes available on the market. So to start with Egypt, we see that most people are using informal products, but some, instead of using the galena lead sulfide stone, are using cotton seeds or date pits or frankincense and grinding that into a powder and burning it so that it can be applied. And in India, it's a much more formal market, but many of the powders that are formally made are already low lead.
So we've seen a lot of differences across countries, but the one thing that seems to be similar across all 4 is users' motivations for using traditional eyeliners. First, people believe that using eyeliners actively promotes eye health, that it protects from illnesses and improves your eyesight. There's often also a deep cultural and religious significance that's attached to the galena stone itself. So in Islam, it's linked to the Sunnah, which is the Prophet Muhammad's teachings on that guide everyday behavior of Muslim people. And so this is not just a cosmetic practice, but is deeply rooted in religion and tradition as well. And similarly, we see surma used in Ayurvedic traditions in India. Of course, people also use it for cosmetic reasons to make their eyes look bigger, bolder, more beautiful. And this is deeply embedded in, this aesthetic reason is also deeply embedded in popular culture. Growing up with Bollywood movies, I can name a dozen different songs where the enamored hero is singing about his beloved's surma-lined eyes. And I've seen this since I've been growing up. But across all four contexts, the awareness of lead exposure through traditional eyeliners is extremely low, between 5 to 20% in the countries that we've visited. Now, in some cases when awareness exists, it does meaningfully shift behavior in the right manner. So for example, in India, we spoke to a lot of parents who said they don't use eyeliners on very young children at their doctor's advice. But in Egypt, for example, when we spoke to people, they incorrectly identified pencils as the high-risk product, which was not accurate.
So that is a rapid, quick-fire summary of the many, many things we've been learning over the last few months. We haven't had time to go into detail, but we would love to follow up after with anyone that's interested. But the question we want to come to next is, so what are we going to do about this? Our hypothesis is that the right intervention to address this lead exposure source ultimately depends on the products that people are using. We think that if people are using formal products, the most effective approach is going to be working with manufacturers to get them to reformulate, and working with governments to have regulation that supports that process. But in contexts like Morocco, where people are using informal products, there's no manufacturer really to work with. So instead, we think it needs to be more of a behavior change approach, understanding how can we shift beliefs and behaviors around these products. There is so much we have yet to learn. Here are some of the things we're most excited to learn about in the next few months. We've launched pilots now in Egypt and Morocco, testing messages to see what are the most effective messages that will get people to stop using these products on their children. And in Pakistan and India, we've launched pilots to try and get manufacturers to remove the lead from their products. And we want to learn how easy is it to reformulate a high lead eyeliner, and how could we leverage regulation to support that process. We want to understand, can we shift people to lead-free substitutes? Are they willing to go from something that's very high lead that they consider authentic to something that's made from, for example, organic matter? And we also want to understand what is the BLL impact of this, and finally, understand other contexts, what's going on. So we're now launching studies in partnership with local organizations in Nigeria, in Bangladesh, and also in Ethiopia.
Okay, so that was a lot of information, but here's the important things that we want you to take away from this. First, in order to understand how much attention and resources to put towards traditional eyeliners, we need better data by country. We need to know not just whether or not people are using eyeliners, but what types of eyeliners they're using and how often they're using them. Countries with large Muslim populations in particular are promising for more research. Second, our findings highlight that powdered eyeliners represent a distinct high-risk category of product, and in further data collection efforts as well as behavior change interventions, they should be the primary focus. Third, we need to understand the market structure and the availability of substitutes better in order to design interventions that are appropriate for a context. So for example, in Pakistan, where there's one manufacturer that dominates, regulation might be really high impact. But in Morocco, where the supply is fragmented across multiple informal vendors, behavior change interventions might be more impactful. Similarly, shifting people, substituting away from high-lead products depends on whether there are safer alternatives available, which we see in Egypt and India. But again, in Morocco, there is an authenticity that the galena stone lends to traditional eyeliners, and so this might be harder to do there. Finally, we need to acknowledge that this is a practice that's deeply rooted in religious and cultural practices. And if we want to reduce people's lead exposure from traditional eyeliners, we need to design interventions in such a way that acknowledges the significance and addresses people's motivations and beliefs.
Thank you so much.
Thank you.
super interesting. And actually, I've been working with our next presenters at. We've been looking at eyeliners like these that actually are on sale in the UK on sites like Amazon and eBay, because of course everything you're talking about is specific to various communities, but these communities exist all over the world, especially in London. So everything you're talking about is as relevant, I think, as well for people that are living here in the UK. Okay, our next panelists are going to be talk about lead exposure risks from commonly used consumer products in Malawi. We have Isabel Armjand, the co-executive director at the Lead Research for Action, LERA. I think most people in this room will know the difference between all the acronyms. Isabel is the co-founder and co-executive director of LERA. Before this, she was working at GiveWell, which is a global health research organization directing hundreds of millions of dollars annually to highly cost-effective programs all around the world. And we also have her colleague, Tammy Tan, who's also co-executive director at LERA. And she was, before this, a researcher at LEAP and has been working all around the world on this and has published many, many papers and journals on this very interesting topic. Thank you so much for coming. If you two would like to take to the stage.
Great. Thank you, Laura, for the introduction. I'm Isabel Arjmand. I'm the co-executive director of LERA, Lead Research for Action, and really looking forward to being here today to share some of what we've been learning in Malawi. Just to briefly give a bit of background on LERA, we are an NGO focused on identifying sources of lead exposure in order to enable their eventual mitigation. So taking a fairly broad lens to looking at estimated blood lead levels are high. For example, in Malawi, they're estimated to be about 5 micrograms per deciliter on average in children, but there's really very little known about where that exposure is coming from. And so this is the sort of question that we are setting out to investigate. Today, I'm going to give you an overview of the study that we completed in Malawi last year, and then Tammy will share some of our key findings, after which I will share our key recommendations and our follow-up work that we currently have underway. So last year, we went to Malawi to investigate the question, which commonly used consumer products are most likely to pose a substantial lead exposure risk, especially for children and pregnant women who, as we've heard, are especially vulnerable to lead poisoning. We looked at 12 different product categories, things like metallic cookware, plastic foodware, spices, staple foods, cosmetics, herbal medicines, etc. And within those categories, we sampled over 750 items and tested them for lead content. In terms of the geographic spread within Malawi, we worked in 3 districts, Lilongwe and Blantyre, which are the 2 largest cities, as well as Salima, which is a more rural lakeside community. And we visited 24 markets, mostly open air, but also some brick and mortar. We paired our analysis of lead content in products with consumer and vendor interviews in order to form a more holistic picture of what might be driving lead exposure. So it's not enough to just know that something contains lead. You have to know more about how frequently it's used, how much people consume. And then with the vendor interviews, we were really also eager to begin to get a sense of supply-side dynamics and supply chains in order to begin thinking about how we might mitigate any identified sources. So we sampled over 750 products and did about 200 interviews. I'll turn it over now to Tammy to share some of what we found.
Thanks, Isabel. So I'm going to go through some of our key findings today. In the interest of time, it's just going to be a subset of all the results that we found during the study, which you can find on our website. There's a full report in the research section of our website. So our first key finding was on plastic foodware. So plastic foodware is really widely used in Malawi, as well as in many other sub-Saharan African countries and many other countries around the world. Unfortunately, we found very, very high levels of lead in plastic foodware with a mean of over 400 ppm. But as you see, there's a long right tail with a maximum of over 7,000 ppm. We found that concentration varied significantly by color. So orange and green foodware came back extremely high, We also found red, brown, and even white foodware to have high levels of lead. Concentration also varied significantly by brand, and 4 out of the top 5 producers in Malawi, 4 of the top 5 producers by lead levels were Malawian brands. Secondly, we looked at these geophagic materials that are commonly consumed during pregnancy. So these are compacted soils, often high in clay, that are commonly consumed by pregnant women in Malawi. And unfortunately, we found quite high levels of lead in these soils as well, with a mean of around 50 ppm. As you see on the slide, there were 2 main types of soils that we found in Malawi. There were these red soils on the left and these grey-coloured soils on the right. The means of these 2 different types of soils didn't vary significantly. They were both around the 50 ppm level, but there was a range from around 9 to 66 ppm. Most of the women that we interviewed during the consumer interviews reported purchasing these soils from markets. Around 70% of women purchased soils mostly from markets, though we recognize here there may have been some selection bias since we were conducting these interviews in markets. The other women reported sourcing stones from home, so either from the walls of their kitchens or from termite mounds in their gardens or near their homes. We found that 26% of women in the sample that we interviewed reported consuming soils, and we actually think this might be a bit of an underestimate because there's some social taboo around this consumption of these soils in Malawi, and so there might have been some social desirability bias going on. In the literature, we see a range of around 30 to 50%. We didn't directly survey reasons for consumption in our survey, but from the literature, we see a range of reasons reported, from general pregnancy cravings to a belief that it helps with morning sickness or nausea, and then potential links with micronutrient deficiencies such as anemia and iron deficiency during pregnancy. This is also consistent with the fact that we found quite high levels of iron in the stones, interestingly, so a range of around 1 to 3% of iron. We did a blood level impact estimate using the US EPA's All Ages Lead model, and using some assumptions based on the data we collected during our survey. We found around a maximum increase of 13 micrograms per deciliter, but an average of 5.2 micrograms per deciliter over the course of a woman's pregnancy, which is unfortunately quite significant and has significant risks for the fetus, the developing fetus. Our third key finding is in the area of metallic cookware. We looked both at formally produced as well as informally produced metallic cookware and found lead levels to be quite high in both. The mean was over 12,000, though this was driven by a long right tail. As you see, the maximum concentration was almost 350,000 ppm. Interestingly, we found actually higher mean levels in formally produced cookware than informally produced cookware, with a significant difference there. This was driven by, again, a couple of pieces that had really high levels of lead in them. And just to talk through some of the subcategories of these 2 types of cookware, on the informal side, we looked at 2 main types of cookware. We have the wrought metallic cookware and the cast metallic cookware. These both had elevated levels of lead, but the means weren't significantly different. Within the formally produced cookware, we looked at a few different types. Some of note include the wrought aluminium pots, which many of you might have seen. They're very, very common across Africa, very common in Malawi, and used to cook many staple foods, as well as other everyday things like boil water. We found a mean of over 400 ppm in these pots, with a maximum of over 1,000 ppm. Then interestingly, we found these another type of formally produced cookware, these imported non-stick pots and pans, many of them from South Asian countries, including Pakistan. These were what really drove that long right tail, with a mean of over 90,000 ppm and a maximum of close to 350,000 ppm. And we're still looking into this more as a subset of cookware, but it seems for now that the lead is mostly in the non-stick coating, which is really interesting, and we're not 100% sure why. Finally, we have a finding on staple and other foods. So we ICP-MS tested 148 food items and found that 24 of them had lead levels above 0.2 ppm. The highest level contamination was in green leafy vegetables. There was also one spice outlier, but we didn't generally find widespread evidence of spice contamination in Malawi. So these green leafy vegetables had very, very high levels of lead in them, and we think it's potentially consistent with environmental contamination. We're doing some more research on this using isotopic analysis. Very grateful to Pure Earth for their funding of this continued research. And we did a blood level impact estimate here too, using some assumptions from the data set that we collected. And we found that both staple foods and leafy greens, if you assume certain rates of consumption, might be associated with an average blood level increase of around 3 to 4 micrograms per deciliter in a child from ages 6 months to 6 years. I'll now hand it over back to Isabel for some recommendations and next steps.
Great, thanks, Tammy. Yes, very eager to share now what we have planned next, because just answering some of these initial research questions is not enough. We have to think now about what we can do to actually figure out how to eliminate some of these sources. I'll start with plastic foodware. So as Tammy mentioned, this is extremely commonly used in Malawi as well as other countries, and we found fairly high levels of lead. But unlike for something like lead in paint, there's not yet an internationally recognized reference level. However, the European Union set a reference level of 100 parts per million as the maximum limit for lead in plastic food packaging, and we believe that this could be used as an interim regulatory limit while more work is done to develop a better evidenced regulatory limit for plastic foodware. In that vein, we have some work on plastic leachability underway in partnership with LEAP and the British Columbia Institute of Technology. We have collected samples from Malawi, Kenya, several other countries, and are testing how much lead leaches from those plates, cups, and bowls into commonly consumed food and drink under realistic conditions. We finished the first phase earlier this year and look forward to sharing more results later in the year. In terms of how mitigation might work for plastics, we believe it might be able to follow a somewhat similar playbook to for lead in paint, based on what we've observed so far about somewhat similar market structures. And so this might look somewhat like regulation paired with technical assistance and support to manufacturers in moving away from lead-containing additives. Next, I'd like to talk about geophagia. So this is common in Malawi. It's also pretty common in other parts of Africa and some other regions in the world as well. But despite that, there's been very little work done so far actually empirically connecting geophagia to blood lead levels. The modeling Tammy shared obviously is very concerning, but we think there's a real gap here. And so we have a study planned for later this year or early next year looking at the association between geophagia and blood lead levels in pregnant women, as well as gathering some other information such as iron status. One of the hypotheses for geophagia is that it's associated with, and the cravings might come from, anemia, and so looking at questions like that. Depending on what we find there, it might seem worth developing and piloting an intervention to address geophagia. This could be an educational behavioral change intervention. It could be a nutritional supplement to reduce cravings. More work can be done to develop that once we know more. Metallic cookware, like plastic foodware, doesn't yet have an internationally recognized reference limit, but the UN FAO uses 100 parts per million as the limit for lead in metal cans. And so again, we believe that that might be an appropriate interim regulatory limit while more work is done to develop a standard. We also believe that this could be addressed by banning imports of non-stick metallic cookware that is highly contaminated, since that was one of the key findings that we had, particularly concerning area. And then finally, in order to address both the formal and the informal sector, we think something will be needed that targets the informal sector specifically, possibly something like training for local artisans on safer manufacturing or materials sourcing, but more work needed there as well to develop something. Finally, for staple foods and leafy greens, the next step is to figure out the route by which these foods are becoming contaminated. This could be uptake from the soil, it could be air deposition, and we have some work planned for later this year looking at ULAB repair and recycling in Malawi. So taking environmental samples, including crop samples, but also soil samples and water samples around ULAB repair and recycling sites in order to better ascertain whether that might be where the lead is entering into the food supply. Depending on what we find there, that would inform what type of mitigation or regulatory measures are most likely to be effective. And then, as Tammy mentioned, we also have isotopic analysis underway. Before I close, I'd also just like to thank our partner in Malawi, the Lakeland Foundation, and James Wera, who have been really instrumental from study protocol development to data collection and the results dissemination that we did earlier this year in Malawi. We're really looking forward to continuing to collaborate, and we hope that this research can lay the groundwork for eliminating some of these identified sources in Malawi, as well as informing mitigation in other countries. Thanks.
Thank you both very, very much. Next up, we've got Nana Yeboah, who is the head of Food Safety Monitoring and Biosafety Unit, the Food and Drugs Authority in Ghana. So sounds very important and impressive. Thank you very much for having us. Nana has over 17 years of experience and has obviously been working on this for a very long time. I see here you've trained over 4,000 people in the food industry to look at this specifically, and you are secretary to the National Food Safety Policy Technical Working Group in Ghana. God, they love these enormous titles. Thank you so much for coming. Please take the stage.
All right, good morning, everyone. I'm Nanikia, as has been mentioned, and I'll be taking us through a little work that we did at the Food and Drugs Authority with the kind support of UNICEF. So just give a brief background about Ghana, FDA, what we do, what was the basis for carrying out these research, the methods that we use, and some key findings, and then some actions that we have taken already because of what was discovered, and then I'll conclude. So most of us may know Ghana is in West Africa. We have about 16 regions, and our population is a little close to 31 million. For the female population, they cover about 50.7%, and it's largely a youthful country, with about 35.3% being between the ages of 0 and 14, and then 38.2% being between 15 and 35 years old. With Food and Drugs Authority, that's the government, we're under Ministry of Health. We regulate the safety of food, efficacy of drugs, cosmetics, and a whole lot. And because of the nature of food safety in Ghana, it's done by a host of other organizations, and we all work together to ensure food safety. So FDA collaborates with national stakeholders and international stakeholders to ensure public health and safety. One of the key platforms that we use is the National Food Safety Policy, which I'll talk about later. So what was the rationale for carrying out this study? In 2022, UNICEF and Ghana Health Service, I think together with Pure Earth, did a survey of blood lead levels in children under the age of 5 years in 3 of the 16 regions. So that was the Northern, Ashanti, and Greater Accra region. Now, Greater Accra region is where the capital city is, and one of the most populous regions in the country. And out of this study, they surveyed 3,225 children, and 53.5% of them had very, very high levels of BLL, above the 5 microgram per deciliter. And they also went ahead to do some environmental study showing linkages with the traditional eyeliners. So this set the stage for us to do further work. But the focus was more on selected food products and some cosmetic products. So we looked at turmeric spice, the ground or the milled one, cereal mixes, the eyeliner, we call it kole or kaji, and then the bentonite clay, that's the white clay, which we call ailo or chile in certain parts, and then skin lightening creams. These were picked because of their wide availability and the frequent use among the populations in the country. And then, like I mentioned, it was under partnership with the UNICEF. So I'll talk a little about the product. So just like we found in Malawi, where they're using geophagic soils, it's very similar to what is happening in Ghana. A lot of pregnant women eat what you find on the right, the edible clay or the white clay. And it's a craving, it helps with nausea, and it's very addictive. And then for the eyeliners, we found these two. We have the pre-packaged ones, and then the ones that it's a stone that they grind into powder form, and they put it in a skin-like container, and it's offered for sale on the markets. And it's very common among the Muslim communities, but it's also gaining popularity among other secular groups. And just like has been mentioned, it's the same thing. It's believed to have some medical benefits to the eye, and mothers apply it to clear their kids' eyes of any infection. And then also for cosmetic benefits, making the eye pop. Those have been the reasons for the usage. The other product of interest is cereal legume mixes. So you could have maize with soybean, with pulses, nuts, all being blended together into what you find on the last end. In Ghana, we call it Tom Brown. It's a very common food in a lot of homes. I grew up eating Tom Brown. One of the reasons why we picked Tom Brown was illegal mining is a serious problem in Ghana. So we wanted to find out if some of the ingredients being used could be a source of contamination for lead. For skin lightening cream, we wanted to find out for mercury whether that could be a source of contamination. I don't want to talk too much about it. I want us to focus on lead. But we also picked skin lightening creams. Okay, so primarily we wanted to assess the compliance of these products that I've mentioned with national and international standards, and then also to find some scientific data based on which we can make regulatory interventions to protect public health and safety. So it was a cross-sectional research design. We sampled from these major sampling points: the open markets, the cosmetic and food shops, the high-end supermarkets, and then hospitals, postnatal weighing centers. It's a common practice in Ghana that when you take your child for postnatal care, you have some women selling cereal mixes and things like that. So we're curious to know what was being offered for sale at those points. Yeah, so it was a stratified random sampling that was used at each point. In all, we picked 1,691 samples from these various points. And it was a national program, so we picked it from across all the 16 regions of the country. So the sample size were determined based on the registration status. For skin lightening creams, we took about 209 samples. Cereal mixes were 278. Turmeric was 12. For some of the products, they are pre-packaged, labeled, and they are registered. Some are sold unpackaged. And so we had to determine the sampling size of that as well using the RALSOFT. And we assumed the population size of 1 million as a baseline, and we found 384 as the sample size for these products. And it's affected the unbranded turmeric, the coal kaji, and the white clay. So we use our lab, we use the AAS. Our lab is accredited ISO IEC 17025. And then we tested for these heavy metals. But for the purposes of my presentation in this meeting, I'll be focusing more on the lead. The results were evaluated against the Ghana national standards and codex and other international limits. Okay, so for the key results, the eyeliner, which is the Kohokaji, across the country, almost 78% of them failed lead. Ashanti, being the second most populous region in the country, had 92.75% failure. We got 100% failure in places like Eastern region and Upper East region. For the regions where Islam is quite dominant, that would be the north, the northern region, the northeast region, Savannah, Upper East, and Upper West. And they all failed quite, the results were quite staggering. Yes, so I mentioned we had the branded and unbranded. So you find that for the branded ones, 50% of them failed. And I was quite interested in your presentation from Malawi, sorry, for the first presenter, how some of the branded ones also were showing very high levels. We also saw that. But for the unbranded ones, which is mainly the stone crushed into powder, they were about 95% of them failed, because we're finding that it's just galena, it's not anything special. And so that is what we found. And what we find most comforting is that if government wants to move towards a ban, there are safer options available for consumers to use. Okay, so for cereal mixes, we were surprised that the lead levels were quite low, 3.68%. Cadmium was our, it's a big surprise to us. That was quite high, even though I didn't show it here. And we realized that Ashanti region, Ashanti and Bono are major growers of maize. They recorded 0% lead failure. Likewise for northeast, northern region, Savannah, Upper East, Upper West. It was Greater Accra and Eastern region. Eastern region is known for illegal mining, so we're not too surprised to find that they recorded some high levels. Yeah, so for the comparison between the branded and unbranded cereal mixes, we found that the unbranded ones were quite high for cadmium. But then for lead, across board, they were around 4.2% failure. Yes. So another interesting point is, for the hospitals that we sampled from, we actually identified some field samples. About 5.88% of these, which are offered to nursing mothers, failed for lead. For turmeric as a spice, turmeric is also gaining popularity among young women because of weight loss issues. It's been linked to help in weight loss. And so when these findings came out, one of my directors, who is a devout turmeric user because she's using it to check her weight, she screamed. She literally screamed. And we found 42% having lead. And most of these products are imported. Even though we grow a little of turmeric, most of these were imported. Yeah, just the original distribution of the findings. So on the market, even when we are sampling, we try to find out what the sources are. They claimed they were local, but further investigations revealed that they are actually imported from Dubai. For the edible clay, we found that about almost 25% of them failed lead. We did further investigations by going to the major mining areas for this white clay. We picked from the stony areas, we went to their processing places. Interestingly enough, the findings that just came out, they were clean. So we are now beginning to find where the sources, it could be from handling, post-handling, it could be from retail. Something is happening that is introducing lead in the white clay. One of the major hubs in Greater Accra where we visited was a place near a mechanic shop. So we are thinking that that could be a very possible source of contamination, but further work needs to be done. Yeah, just showing the samples that were picked from the open market and then the retail shops. Yeah, so seeing these staggering figures for lead contamination and in coal, turmeric, and other products, for coal, we found lead levels up to 11,000 ppm. Interestingly, again, skin lightening creams were found to be clean of mercury. They were very compliant, owing to the lot of work that FDA has done in the past. So we're not too surprised with that finding. So what actions have we taken so far as a regulator? We have done product recall for the implicated products. When the team went back to market, majority of them were already off the shelves, but then we're still able to trace a couple of them. The findings for cereal mixes revealed the need for us to include cadmium in our national standards. As it stands now, when you're bringing a product for registration, there's no test for cadmium. But this revealed that there's a need for us to include it. So that has been done. Drinking water specifications and for cocoa products have also been rectified. And we are also trying to strengthen our border controls. Majority of these products are imported, apart from the cereal mixes and the white clay. And then for the cosmetics department, we are trying to review our guidelines. Coal hasn't been something we regulate. It's not been in our radar since God knows when. But these findings have opened our eyes to the need to find a way, even if it's in the informal sector, find a way of bringing them under the regulatory umbrella. So the guidelines are currently under revision to have that done. For the food commodities, we are through the National Food Safety Policy, bringing together all stakeholders. Now, other institutions have done some work on cookware. Others have done on drinking water. So we have brought them all together to develop a national strategy to reduce heavy metals in food. That is in the draft stages. And we will continue to work closely with all our partners, and thank you so much for UNICEF and anyone who is on board to help us protect the people of Ghana. And I think this program is very important because whatever affects Malawi, whatever affects Pakistan, eventually because of trade will come in. So it's good that we all work hard in our various roles to ensure safety of the people of the world. Thank you so much for your attention.
Thank you very, very much. Okay, next up we have a talk on lead acid battery recycling as a source of lead exposure. I'm sure you all read that New York Times investigation, which I thought was incredible. We have Andreas Manhart, a senior researcher and co-head of circular economy and global value chains. Would you like to start?
Thanks a lot. Mic is on? Right, I'd probably start with a quiz. This is a real case, you have to guess the country. There was a battery recycling company that also produced lead acid batteries, and it emitted lead dust to the neighboring community. Part of the facility were erected without permission. There were several fire outbreaks because of unsafe operations. And it took 6 years from the first complaints until the authorities stepped in and closed the facility because the owner was a minister of government. What country am I talking about? Guesses? No guess? Nigeria is a big vote. Another one? Kenya. It's Germany, back in 1985. So this probably reminds us that the problem I'm describing is not something many of us might think are only in low and middle income countries or down there in Africa, and up here we are safe. These interventions, these political influence we speak about, Phyllis mentioned this morning, they're risk everywhere, and they also remind us that we should probably be a bit humble in the global north. They also remind us that things can be changed quite quickly if we all want to. But let's now come to Africa. Sorry, the Africa map doesn't show up well. There should be also a bit of a continent around it. Basically, what I'm talking about is work we have done, I think, in the last 15 years. And the marked countries are those we worked in or have good networks to. The last three, the dark marked, Ghana, Nigeria, and Tanzania. This is where much of it is based on because we have done investigations with authorities in the last 3 years and have a very good overview about the rural recycling sector. All this is not done alone by us. We always partner with authorities. We always partner with very strong groups on the ground. Tadesse from Ethiopia, Phyllis this morning, Gilbert from Cameroon is also here, and many more. So basically, what are the current end-of-life management patterns? Simplified, we all know that labs are used in a variety of sectors, and if a user has a battery that fails, many of them take them to a repair shop. And the repair shops are out there, they refill the acid, they exchange a plate. Chris Kinali has done an excellent study on this in Malawi. These sectors exist basically in all African countries. But if a battery is beyond repair, it's given to collectors. And the collectors, they basically either open the valve or they punch a hole in the battery and drain the acid. And they're doing this because the customers ask them to do so. And their customers are basically industrial lead acid battery recycling plants. They're actually quite big and they buy the supply from the informal sector. They produce basically refined lead and lead alloys, and they either use them in own battery productions. Some of them have own battery productions in Africa, or they sell the lead alloys and the refined lead to the global market. They also produce a plastic stream, which is not always so clean, and they, of course, produce slags, which are very often disappearing, disposed uncontrolled. And it's on the one side, it's a circular economy. The lead, of course, goes back into products in the same or in other countries. There is a big talk about informal and formal sector relationships. In all the countries, we realized, this also the colors don't come up well, that the left part is very strongly dominated by the informal sector, while the recycling is strongly dominated by the formal sector. So we don't really see the pattern, the described pattern of competition. It's more a cooperation. So the informal collectors supply the formal plants. And let me allow a comment, because there is, I think, a bit of a potential research bias at the moment. If you look at informal and sector from space, informal very often looks a bit like to the left and the formal to the right. So if researchers come into a country, it's quite easy to enter an informal sector. You might need a local guide, you might need to speak to the chief, but then you can do the research. If you do the same with the formal sector, your research ends up at the gate. There is 3 reasons you can go in. You're either a business partner, or you're a worker, which I hope you are not, or you come with an inspecting authority. And I don't say we should not do research on the informal sector, but just because there is more publications on informal sector, it does not mean everything is done in the informal sector. The formal sector, where are they? They are operated in clusters. Basically, we have this Nigerian cluster with 10 industrial plants. We have one in Ghana with 5, and there are more. There is nobody out there who really knows how many plants are operating at the moment in Africa. We roughly estimate well above 200, with the number increasing. This is how they look from the outside. This is not the informal sector. This is a large-scale investment. And you see from the smoke that probably it's not operated as it should. If you walk in and this to time constraints, just some impressions how things can look like. It's not that they always look like this. This is battery breaking, so the battery needs to be opened and the lead extracted. This plant uses a battery saw, and what you see here, basically, you see from the residual acid in the batteries, this is splashing onto the wall, and it's corroding the wall. You see the worker's hands getting a centimeter to a quickly rotating saw blade, extremely dangerous. And you see this white swampy ground. It's white because they applied caustic soda to neutralize the acid. They learned we are coming the day before, but it was a swampy ground of lead material and sulfuric acid. You may argue this is terrible working condition, but it's not population lead exposure, only few people really working there. It's true, but we see that plants that don't care for the workers also don't care for emission controls. It's symptomatic. This is a rotary furnace, and most of the plants use rotary furnaces. There are other furnace designs. On the one side, this is a furnace that is useful. It's quite versatile. It can recycle residues out of the production chain again. On the one side, yes, this is a modern technology, but this one has a tiny fume hood, which is actually not capable of extracting bypassing fumes and dust. Completely substandard. You also see this platform, and it basically tells us that the workers have to charge the furnace with shovels. This is a 10-ton furnace. So they have to shovel in 10 tons of lead material while the furnace is open and hot. And you see the tapping port. And whoever has been to a lead plant like this knows that tapping, in terms of emission control, is the most critical step. If this is tapped within seconds, the hall will be filled with lead fumes. It's not ventilated at all. So we have a good furnace which is operated completely substandard. And this is very symptomatic of what we see in the plants at the moment. Filter plants. All of the plants we visited in the last 2 or 3 years had almost a complete off-gas treatment system, which is good news. So they have cooling towers, they have baghouse filters, they have stacks, some of them even met scrubbers for the sulfur. This is somehow of the better designs, how they look like, but also here we see many of them are actually not how they should be operated. This one is completely substandard, it's a self-made one, which is actually not very effective. It's poorly maintained. We very often see that they capture emissions, but that the powder dust is released at a later stage again. And we all see in this case that we have a widely unprotected worker in there in the probably most hazardous position in a lead plant at all. I could show hundreds of such pictures, but we run out of time. There is, apart from these negative impressions, also some positive developments we can report from. First of all, lead smelting and melting is predominantly done in registered formal industries in Africa at the moment. They have the investments on the ground, they're known to the government, they can't run away. And the governments, all of them have existing licensing and monitoring systems. It's not like the governments don't have these systems in their routines. And we've seen actually quite promising enforcement campaigns in Kenya, Nigeria, and in Ghana. Kenya, of course, also triggered by Phyllis activities. And we have the worst furnace designs had been phased out. So the left furnace you see is a blast furnace. When we started this work, most plants had these blast furnaces, which are virtually impossible to control. We have not seen any in operation in the last 3 years. So they use these rotary furnaces or other furnaces, better controlled, not perfectly controlled. I don't say everything is solved, but we also see some development which probably should give some hope. We also have seen that there are now emission control systems, as mentioned before. It's for the management not possible to apply for a license without having any emission control at all. At least it must be there. This is what the authorities demand. So we see some influence onto that market. And we've also seen some limited investments in some better plants. So there is room for hope, although the situation is not yet perfect. Some economics. People ask us, how much would it cost to bring a plant, as just described, up to a standard we could probably call responsible? So the figures for what have they invested at the moment for this average African plant with a lead output between 10 to 20,000 metric tons of lead per year, this is what we estimate they put into the plants at the moment. So for the hardware only, between 3 and 8 million US dollars. If we would like to, build a plant with the same capacity that is from a hardware, something you can operate responsibly, we would be at between 13 and 27 million US dollars. So should we shop around and collect money and strike a deal with recyclers? We make a deal, we make a plan, we supply you with equipment or you pay you the equipment to upgrade. I'm afraid it's a bit more complex. We have to understand that ULABs are internationally a traded commodity, and they're traded based on weight and factors. So they take the global world lead market, takes the weight of a ULAB delivery, multiplied with the price for lead fixed on the London Metal Exchange, multiplied with a factor. And the factor is plant specific. So 2 years ago in Nigeria, the best performing plant, which was really good, could apply a factor of 0.5 for the best price. So they offered 1,000 US dollar for 1 metric tons of ULABs to be delivered at their gate. At the same time, in the same location, their dirty competitors could offer 160 US dollars more. So you can guess where most ULABs went to. So we can conclude that if there is a widely unregulated market, a high standard plant will have severe difficulties getting enough battery for recycling. If you was ask me if I would put my private money in a sound operation in Africa at the moment, I would love to do so, but it's very risky. So it comes to what should we do? Summary and policy implications. Sorry for hammering on informal formal sector interactions again, but I still read policy paper, quite recent ones, arguing that the main competition is between informal and formal recyclers, that informal recyclers would pollute more, and that is enough reason that we should give advantages to formal recyclers simply because they're formal. I think in sub-Saharan Africa, this is dangerous. This is counterproductive. We have a situation where informal and formal sector cooperate, where the informal sector responds to what the formal recyclers demand them to do. and where probably the formal recyclers are amongst the biggest lead emitting entities in the countries. Should we really give them a tax holiday? We need effective sanctions against polluting entities. High standard ULAB recycling can only prevail, only succeed, if there is a sanctioning regime. So we need regular controls of the plants, we need ambitious improvement plans, we need sanctions. And for this, we need the partners in the countries. The only people who have the mandate are the authorities in these countries. We must work with them. We need a market consolidation, and there we have to understand, for understandable reasons, most low and middle income countries, they want foreign direct investments. But the government authorities who speak with investors are not the environmental authorities. So the other authorities, and they want to attract businesses. And for them, battery recycling makes all the ticks. It's modern, it's recycling, it's job creation, foreign direct investment. So we must reach out to them and say, you need a strict door. The more investors you let into the country, the more competition, but the same battery volumes. The more competition, the difficulty it will be to really upgrade plants, and you will have losers. You will have plants who give up. You have a growing number of contaminated sites. At the moment, we see overcapacities in all African markets, formal overcapacities. So we must work with a wider range of government who speak with investors, also to convince them to apply other policies in this particular sector. The polluter pays principle must be given a life again. It's embedded in most legal systems of most African countries. At the moment, we have a lot of pollution cases. Phyllis spoke about them. There is no single case any of the plants has been held liable for remediation, for health treatment of victims, for compensation payments. The only court case that was successful was in Kenya, but the plant ran away before it was enforced. It's not only a justice issue, it is a justice issue. But when the plants learn that they're held accountable, they will learn that it's probably cheaper to prevent rather than be bogged down in court cases and to pay compensation and remediation. We can and we should think about remediation and whether this can be financed from international sources, but for justice reasons and for economic reasons, it's important that the polluter pays principle is applied here. We need regional exchange. We have a lot of promising policy initiatives in a number of countries. Many of them still work in isolation. We must strengthen them, give them opportunity exchange to learn from each other. Supply chain due diligence, I think it should be a normal thing that lead, which has hazardous properties, is something where a buyer looks closer. Things where it's coming from and whether there is an environmental or human rights risk attached to it. But I think we need an intelligent system. There should not be a tick box system where buyers say, I buy the lead from OECD countries and let the others buy the dirty lead. There must be an intelligent system where responsible buyers engage and say, I, with my purchasing policy, strengthen the better part of the industry in low and middle income countries. Improved monitoring, I said, we can't replace the investigations by the authorities on the ground, and we must strengthen them, but there are various layers possible of monitoring. In our countries, in Germany, we have stack monitoring with a live link to the authorities. There is pollution we can see from space. I took this from Google. I've never been to this plant, but there is strong visual indication that this is probably not the best managed plant. So we should explore also these remote monitoring systems. And it's not only because we want more data. You might say when I say we have to work with governments, yourself I reported from governments in Germany some decades ago where there was corruption, political influence, where the government was not strong. This is a risk we face all over the world. When we have various layers of monitoring, it's also for, if there are corrupt elements in an authority, more difficult to accept a bribe and to sign off a license. So these monitoring layers have various functions. And the role of international donors and experts. In all the countries we work in, we have an extremely high motivation and committed people on the ground. These are the people who are personally affected. This is an urban and semi-urban pollution aspect. This is where the people live, where the families live. We must strengthen them. I see a bit the danger that with this huge opportunity we have, we might build a lot of careers and organizations who are really committed, but probably neglect those who will stay behind. Every funding line in a certain point in the future will go down again. When it goes down, we must have achieved that in the countries there is enough capacities, careers being built, organizational capacities to keep on advancing this subject. Thanks for this short overview. Happy to exchange further. Thanks a lot.
You guys want to come up? Do you want to take a seat? Take a seat, please. Thank you. I enjoyed your German example because I love to talk about how we, in countries of high economic development, etc., we are also way behind the times. And listening to what's happening in Ghana compared to what's happening in the UK, that was incredibly advanced. What you've done there compared to what we're doing here, we're not doing anything like it. So quite extraordinary. I will open the floor to questions because I'm sure you have much better questions than I do. But can I just ask, this is a very broad overview question, and it's this sort of two-pronged. What is the biggest barrier to governments not dealing with this problem? I'm thinking about the cost of dealing with this. And then what is the biggest incentive for them to do something? Again, I'm thinking about Ghana. The fact that you actually had the blood lead levels in children, that was the thing that prompted authorities to go and find the source. So sorry, it's a very broad question, but yes, what is stopping them, and what is the thing that's going to make them actually do something with your findings?
Thank you very much. Yeah. Why is she not talking? Okay. Can you hear me? No. Maybe I'm loud enough.
You're quite loud.
So I think the absence of data has been a challenge. Because if you do not know, then you can't take any action. But the commitment of our management is something I have to applaud. We are about protecting public health and safety. That is what the taxpayer gives us money to. And so if we're able to... She's not even holding it near her mouth. If we're able to commit as a country to protecting public health and safety, then everything that needs to be done... She's on the handheld, but... Including it in our budgetary allocations, it's essential. But then research is also very important. We are mainly a regulator. We need the support of the research academia to support us in the fight against lead. Give us something. So I think the commitment is important, but data is equally important.
Can I offer as well? Yeah, I think something that we saw in Malawi was that there was, again, a lot of political will, and it was really cool to hear that in Ghana you have the capacity to do lab testing with AAS and other methods, but in a lot of other countries there isn't the lab capacity to do testing, especially on items that have low limits of detection, where like foods and other items where even low levels of lead are really dangerous. And so there's this question of, even if we identify the problem now, how do governments continue to enforce any standards in the future? And how can we make continued testing, monitoring, and enforcement sustainable in these countries going forward?
Yeah, if I can add to that, I think something that we've seen, particularly from the traditional eyeliners work, is that ultimately the barriers to progress and the incentives to drive it are so source dependent. So if we're trying to end lead exposure on a population level, we're all doing work to try and break down what are the main exposure sources. And once we've identified an exposure source, the next bit is, okay, what are the barriers to progress here, and how could we unlock those incentives? But I think we all in this ecosystem need to be going source by source and mapping that out separately, because once you get onto I think the opening words of Phyllis were incredibly powerful, and that's something I'm walking away with today. But ultimately, like with traditional eyeliners, in the formal sector, it is a money issue and there's profit that's going into it, but there's also cultural beliefs. And we shouldn't underestimate the power of cultural beliefs, and we need to respect those and also figure out how do we drive progress while respecting local culture. So really every source is its own set of challenges and opportunities.
Right, I can only speak for the ULAB scene. I think in most governments we worked with, they're in the beginning where there has not been a scandal. The authorities on a high level are not so much aware. It's just any industry for them. So their task is to monitor industrial development, and so they audit, a warehouse, they audit a steel smelter, a power plant, a hotel, and the next day a ULAB smelter. So they might have the feeling things go wrong, but they're not strengthened because there is no priority. So after some awareness raising or a scandal or both, this normally changes. And then the next need is basically, how can I basically demand, what kind of upgrades can I demand? Because they must go in with a technical description. They can't just throw out an investor out of the country. They need to specify the expectations. And then the third level is when they're able to do this, it's a power struggle. On paper, the environmental authorities can shut them down. In reality, of course, the powers to be, these are foreign investors who have, of course, their lobby. And then it's not only science, then it's a power struggle.
I know, I'm thinking as a journalist when I ask this question, but for me, in getting even my news desk interested in this story, it's been about turning it from a hypothetical risk. Here's something we know is bad, you can't see it, it's there, it could be really dangerous, we know it's really dangerous. And actually getting people to understand it has been through real life examples of real children, real people, real farms that you can point to. I was thinking in your case, you'd want real workers and you'd want to test their blood lead levels because, I mean, that feels like that's what everyone's talking about. That is the scandal. But unless you have the people, governments could just continue to ignore it as a sort of academic hypothetical risk, which I know everyone agrees with and they dismiss, but unless you have populations wound up going, oh my God, I can't believe this has been allowed to happen. I can't believe my child has had this happen to them as a result of these lack of regulations or whatever it might be, or the food I was buying from the supermarket and feeding them. Nothing will change. So I'm just interested in the order you think things should happen and what is most effective. So I'm just thinking journalistically, if I was going to write a story about a lead battery plant, the first thing I would do is I would want to find an example of workers that had elevated lead levels as a consequence. Obviously, I wondered, and Ghana is such an interesting example of you did do that, but with you guys, when you're testing things, your curiosity must extend to what does this mean for these people that we're interviewing who have told us that they're using these products? But is that the bit that's a bit scary for governments that they maybe don't want to do because it does tip this from the hypothetical into the real?
I think I definitely agree. I think it's really important to do blood level testing and to make it about the people who are being affected by the issue. I think something that has been really striking in our work is even before we do any blood level testing, people are actually really engaged and interested in the results because they see the items that we're testing and they see the results and they're like, I use that every day. It's like the turmeric. People are so upset because these are products that they buy, they eat, they have in their homes that they give to their children. And so even at that level, I think there is a lot of interest and will to do something about it. I don't think you really need to, well, actually, in some cases, I think you do need the blood levels to convince the government, but in a lot of cases, people are already really shocked by these source level results, and that can already get you really far when it comes to implementing action on these sources.
Yeah, I think to add to that, on a government level, talking about what does lead poisoning on such a large population scale mean for the economy, and you can sort of tailor that message depending on who you're engaging with. But I'm going to Morocco on Monday, and I will be meeting with communities and testing different messages of what is the most effective way to make someone understand that this product that they've always considered safe is actually potentially dangerous for their children. And it's not a straightforward conversation, especially if it's something that people have been using for many years. Lead poisoning is often invisible for a long time. So it's really hard to make the invisible visible. So hopefully next year when we're back here, we'll be able to share, well, here's what we've learned. Here are the messages that are most effective at shifting that belief and that behavior.
I mean, in ULabs, there have been studies, and some of them have been there long before we went in. So in one case, I remember authorities giving me a study. They tested the blood of workers. The top level was 278 microgram per deciliter of blood back in 2011 already. So there have been studies and at the moment, sorry to say this, but call for more data and research is sometimes also used by people who don't want to see the action. So there is enough evidence if a smelter is smoking. If there is no emission controller functioning in place, I don't need a study, I need action. So we need data to convince, but there is also a boundary where more research will probably not give more information, but delay action.
Yeah, just to quickly add to that.
There's a new study I just found out. I don't have much detail, but then in the northern parts of Ghana, some district, they sampled blood levels of children who use the eyeliner, and it was very high. So we are seeing direct implication of the eyeliner in the blood. Our concern has been, okay, finding out all these things, we need to connect the dots. Because our EPA is doing some work on the atmosphere levels. We are finding that agro inputs could have, for cadmium and other sources. So we need to connect the dots with the food. If you look at what I showed, for what Ghana Health Service did for the blood levels, that's brought about this whole study. Ashanti region was implicated. Greater Accra was implicated, Northern region. And you see the same trend with a product that we sampled. These are recording very, very high levels. So we need to find a way of connecting the dots. And for Ghanaian consumers, they can be very vicious. You go on TikTok, on Instagram, and they are practically giving it to us. And so we cannot but take action to protect the people.
Okay, does anybody have any questions for the panel? Yes, gentleman at the back.
Yeah. So this is Mahbub from ICDDRB Bangladesh. I'm really inspired by see this encouraging talk from all the presenters. At the same time, it's really a great topic that need further attention. My question is, we all know like that Shurma, lead acid batteries, cookware, many other pieces, paint contains lead, no doubt, all these including cookware. But we don't know many of these exposure pathways. We know some of them, we had some intervention, we delivered it, but still we don't know the exposure pathways and then further true action on designing the interventions. I want to give an example. We know that cookware contains lead, even high lead. Many people, millions of people, they use the cookware. Whether we are able to say that stop using the cookware, it's really difficult. Then you need to change all the cookwares from all the millions of households. It's a big challenge. Similar to these batteries, like many countries, they have millions of easy bike. Each of the easy bike, they have 5 batteries. And the warranty is 6 to 9 months to 1 year. Every battery is going to the informal sectors. So how to deal with this? So these are many pieces that contains less contributing to the high blood lead level. So across the countries, as a global team, how we can synchronize and work together to contribute these issues. So if you can highlight a little bit on this, that might be great. Thank you so much for all the great talk.
Does anyone want to take that on?
I can probably, turn the other way around now. Yes, I think we certainly need more applied research. This is true, and when I say my first claim is we don't need so much research, this is only partly true, because indeed for framing intervention in USMO, for example, when the informal sector drains off a battery, how much lead particles are spilled out and what do they do in the place they end up? This is certainly something which is a bit under-researched. What I want to say is we should probably do this research, but it doesn't have to be replicated in every country, in every city, because the patterns are, despite differences between countries, the batteries are very similar, the patterns are very similar. So yes, we need more research. And I'm not an expert on cookware, but I assume it's similar if there is an aluminum alloy with a certain percentage of lead, that it might behave very similar in different contexts, even if the food is a bit different. So yes, research needed, but probably not. Let's not get bogged down in endless research.
Any more questions? Yes, the lady in the front.
E from Vital Strategies. I think my question is mainly for Tammy and Jake, but also for other panels. It's interesting to see you included the estimation about the different sources and how that contributes to the blood lead level. And it comes from like half microgram per deciliter all the way to 5. So you mentioned about the availability. How certain are we with the research there? What do you think need to be done more? And the question kind of to Nana, but other panel is like, how do these inform policy? When you see a different contribution, different sources, does that influence where do you want to act first?
Should I? Okay, maybe I'll take the last one. I think I mentioned during my concluding remarks that as a country, we are coming up with a strategy for heavy metal reduction in food. And we are doing this it's not a sole project by FDA, it's by every relevant stakeholder, including consumer protection, including private sector. And we are delineating the roles of each institution as to what they should do to ensure that the food that is being made available is safe. So from the Ministry of Agricultural point of view, to agro-input dealers, to EPA, we are all coming up, because each of these institutions have their jurisdictions. They have laws backing the work they do. And so we are working together to form, it's a coordinated effort. It's not going to be done in silos. We're working together to ensure that we reduce lead contamination. And we are also including the environmental factors. So EPA is playing a key role in this. I mentioned that there's a push to, as it were, ban the coal, the galena ore. That is also something that has been informed by the findings of this study. There's a lot to be done. It's a step by step, but then I'm sure we'll get there eventually. Thank you.
Yeah, thank you. I'll just answer that quickly from my perspective. So granularly, we used bioavailability of 0.6 for the soils, which is the default value in the US EPA ALM for soil. We talked to Dr. James Brown about this. He's the one who built the ALM, and he said that he thinks it's a pretty defensible estimate. The US EPA actually has a really fantastic report that lays out why they believe different compounds have the suggested RVA values, and you can read that if you're really interested in the technical details. But we do recognize that, and for the food, we use the value of 1, which is also the default for food. But we do recognize that, especially for something like the soils, there is a lot of uncertainty in how it is absorbed and what the end-line blood level impact is, which is why Lara will be doing a follow-up study later this year to try to quantify the actual blood level associated with the consumption. You also have to make a lot of assumptions around like volumes and rates of consumption, and that's uncertain and variable within a population. Another interesting thing is that we're working with another scientist at the EPA to do this. I don't actually understand this analysis because I'm not a geologist, but it's like he can actually look at the different isotopes, I think, in the soil, the different isotopes of lead, and spit out some number on bioavailability. So he's doing that analysis, and we're really excited to see what comes out of that too.
Yeah, the bioavailability question is a really important one with traditional eyeliners because lead sulfide, which is the rock that's being used, we know has lower bioavailability than lead chromate, for example. And what we've been doing, so until now, there's basically no understanding of what is the BLL increase from using traditional eyeliners. So we've taken lots of different sources. We've taken the literature, which has a huge range. We've used biokinetic modeling from the all ages lead model. We've used other models and then been super conservative in discounting all of that. And we still end up with, for frequent users, this range of 1.5 to 3.6. And that's with a lot of discounting. So this is something that future research is needed, and we're also Dr. Yuhash in Australia is doing incredible work looking at the bioavailability of lead sulfide. I mean, just to get very granular with you, forgive the pun, is once you grind these powders into these rocks into powders, we don't know if the bioavailability increases as a result. So there are so many layers of complication to this, but a sort of a pragmatic and important decision that we've made is, well, we need to land somewhere so that we can advance the fight to actually end this form of lead exposure, because we're confident that there is some BLL impact. We don't know how high it is, but we know it's significant and we need to do something about it. So that's why, in coming back to one of the previous questions, any research we're doing needs to be thinking about what is the intervention going to be to end this form of lead exposure. And the questions we include in our research need to be thinking in advance from day one of the research. What is the intervention going to look like, and how can we make sure every day of research what we're doing is towards that end goal of we got to get the lead out of this. So ask the questions today that help you get the lead out of it tomorrow.
I think we need to end on that beautiful last line. Thank you for ending.
Thank you all for joining us this session afternoon. It was great to see a lot of familiar faces, but also new faces. So thank you for being with us. So today's section is going to talk about the pathways to build blood-led surveillance, particularly in low middle income countries. So I think as scientists and public health professionals, we all have seen how data has been very critical and important in driving policies as well as public health actions. However, these data are often missing in many countries because of the lack of monitoring and surveillance systems. So how do we start? What does the process look like, and what are some challenges and solutions? So today, during our session, we have 4 amazing speakers who will be sharing their experiences from different countries and at different stages of a blood-led surveillance. So we ask you all, please save your question to the end. My colleague Audrey is going to moderate a Q&A section at the end. Without further ado, I'll invite our first speaker, Dr. Grace Gyro, to share her insights on how to evaluate the readiness of laboratory to support blood-led surveillance. She's the Senior Director for Laboratory Capacity Building Initiative at CDC Foundation. Grace, the floor is yours.
Thank you. Hi, everyone. It's good to be here. We missed out on last year's conference, but it's nice to be here to talk about lead and particularly talk about laboratories, which is my favorite thing to discuss. So my presentation is just going to go briefly over what are some things that we think about when you think about laboratory capacity and readiness for BLL testing. It is focused only on BLL testing for the purpose of this presentation, so I will not touch much on the environmental testing and other matrices as well. So let's get into it. So as we all know, and as we had so many times this morning, exposure to lead is often silent. We do not know the symptoms until it's sometimes too late. And so the only way to know if you're exposed is to do a blood lead test, right? So because the symptoms are not visible. So the core measure that we use for clarifying exposure and to make sure that we have data to help us make decisions on how to treat or how to remediate is to do a BLL test. However, the data that we use for that needs to be reliable. We need to be able to trust and be confident that the data we get is actually accurate, is reproducible, and is useful for our decision making. And then the results from that then can be used to trigger action, be it to inform clinical decisions or to inform larger policy level decisions. So when you're evaluating, when you're thinking of BLL testing capacity in laboratories, you start by evaluating laboratory capacity. And at CDC Foundation, we've been working to create a laboratory capacity assessment tool that can be used to assess whether the lab is ready to produce quality data that can be used to make decisions. And this is just a few of the domains that the lab capacity assessment covers. So laboratory role, accessibility, so who can use the lab and for what purpose? What systems do they use for sample collection? What is their rules on the sample acceptance, tracking, reporting? How reliable is the process? And then can the lab test for blood lead, of course, and what technology do they use? Power, other infrastructure considerations like power, HVAC, storage, waste management, all of that. And then just knowing if we use this laboratory for BLL testing, are the results going to be consistent over time? If we want to go back and assess changes due to policy, can we use the data that was collected 5 years ago and compare it to the data that we collect now? And are we confident that those 2 data points are comparable? And then, of course, training, and then what investments are needed for scale up. So the summary of it is, can the lab support surveillance? So it classifies them. This is very generalized for how the classifications work. So is the lab ready now? Is the lab does it have some things, but it's not quite ready yet? Or is the lab absolutely not ready, where we need to start almost from scratch to get them to the point where they can do BLL testing? So the capacity assessment does that, all of that for you. and helps to identify which of the specific areas needs a little bit of capacity building to enable the lab to produce reliable data. So going into blood sample type and the quality of how it affects the quality of some of data that we get. So the two main sample types are venous or capillary blood. Sorry for, I don't know what happened with the system over there. But so venous blood is typically preferred for accurate quantification. It's really useful for confirmatory testing and also for reference methods. In most cases, it supports the broader work of surveillance estimates and trend analysis, and then has a lower environmental contamination risk. The capillary blood is really useful for screening. So when you're using something like LeadCare, which is a portable ASV instrument, it comes in handy and it's very quick to identify where there's exposure, and then that can trigger additional actions, whether it is confirmatory testing, whether it is referral for treatment. So there's a few methods, and this is just a summarized version of the three main methods that we see quite often, which is the portable ASV is also the technology that the LeadCare 2 instruments use. It's very field-friendly, doesn't require much volume, just a fingerprint capillary blood works, and you get your results right away, and you can move on to action. It's limited by higher contamination risk, and also has a limited analytical range. And when you use this, you need a proper confirmatory pathway if you're going to move forward to treatment. For graphite furnace atomic absorption spectrometry, uses venous blood. It has relatively low detection limits, doesn't require too much sample volume. It's a very established technique, is actually pretty accurate at doing measurements and produces consistent results over time. And the limitations, it has relatively lower throughput compared to ICP-MS, requires skilled operators, and has a very sensitive workflow, but it's relatively easy to use and cheaper. ICP-MS is on the higher end of the spectrum, very expensive, but can get you to really low detection limits. So I'm thinking of countries that have already done some work to reduce levels to reduce exposure, where the levels are coming really down. You need to be able to measure below that 3.5 limit for the US, and also below that 5 micrograms per deciliter limit for the WHO threshold. So has a really high throughput, can do multi-element testing, which is an added advantage for laboratories that just don't want to analyze lead, but want to do multiple other metals. Of course, it's very expensive and requires advanced infrastructure and high levels of expertise to operate. The other thing to consider is contamination control, which is what I preach constantly when I speak to laboratories. If you don't remember anything else from this presentation, remember contamination control is your non-negotiable, right? You can do a lot of measurements, but if you don't have any way to control contamination, then the data you're getting is not accurate, is not reliable, and might just be a representation of what's already in the environment that you're testing, and not necessarily what's coming out of that blood sample that you took. So again, clean collection sites, clean puncture sites, so very clear protocols for cleaning the puncture sites, certified supplied, controlled lab zones. So that's very important as well. Make sure that the space that it sits in is not, is free of dust and too much movement and cardboards. And lead is very pervasive. It shows up in so many places. And so those can be sources of contamination. And then also, making sure the sample preparation process is traceable and you're using the appropriate quality controls throughout the process. And talking about quality control, there's many ways to do quality control. Regardless of the method of choice, there's internal quality control and external quality control. And then if you don't document anything, it wasn't done, right? So part of the thing with laboratories is anything that's done in the lab needs to be traceable and documented. So internal quality control is things like including QC samples with every batch, doing calibration verification, reagent lot checks, lot verification of tubes, which is an important part as well. External quality assurance refers to participating in external quality assurance programs, such as a PT program. PT is proficiency testing here. And then also making sure that staff performance is assessed over time and the retraining is done as needed. And then the other part is just documenting everything. So, you have clear SOPs, you have clear QC processes. You document whenever there's failure, QC failures, and corrective actions and performance actions. So, again, without proper quality management systems, do not even try. So the common implementation challenges that we see are pretty predictable, and they can be managed in the lab. So this range from pre-analytic to data systems. So a few examples are contamination during collection and processing. You can create strict collection SOPs, make sure the staff that's conducting the sample collection is well trained to mitigate any possible contamination of sources, using clean supplies and clean areas. And it goes all the way to data systems, making sure you have proper workflows in your data systems, that you have clear sample IDs, no mixing of things, no mixing of quality control materials and actual testing materials. And then other things like infrastructure, power instability, HVAC, those are very common challenges that we see in low and middle income countries. And those part of the mitigation for that is making sure that when a laboratory is set up, all of these things are considered at the beginning. It's not something you want to run into later on. So before a lab is set up for BLL testing, the capacity assessment tool will actually walk you through the steps of what you need to check. Right? Do you have the correct power backup systems? Do you need to invest in quality management systems? Do you need to sign up for instrument maintenance system? So all of that goes into a capacity assessment tool that you perform before making sure that the lab is ready for BLL testing. If you're going to scale, do not scale faster than the quality. So remember, quality is key, right? You can have the instrument, you can have the staff, you can have everything, but if you're not producing quality data, might as well not do it at all. Because we want to be able to compare, if we are looking at impact of policy, we want to be able to compare what happened 5 years prior to data that we collect 5 years later. And if we cannot trust that, if the laboratory team cannot give you the data with confidence that it's as accurate as they can possibly get, then it really affects the quality and downstream effects of the decisions that data is used to make. So a practical pathway that I came up with is to assess readiness, select which model you want, and that is picking the type of instrumentation based on how much money there is to invest in this, what kind of infrastructure is already available, what kind of testing the lab already does, how much expansion is needed, and then building contamination controls, making sure you have a proper QA, QC system, which is we refer to as quality management systems. And then if you're doing capillaries testing, also ensuring that there's a referral lab pathway for high results. If you identify a high result, what do? You need to do confirmatory testing. Do you have capacity to do that, or do you have a pathway or a linkage to another lab that can do confirmatory testing? And then, of course, a big investment case is making sure that's connected to the surveillance goals of the country, and then making sure that your lab is able to do data use case that can be made to investors, can be made to the government, or whoever controls the budget that goes into the laboratory systems. Very important. So my key takeaways, the reliable surveillance requires laboratory readiness. So before doing any surveillance, before you start a surveillance system, ensure that the laboratory team, relevant laboratory team, is pulled into the discussions at the beginning. Do not wait until there's a surveillance protocol and then call the laboratory and say, can you do this for me? Because the laboratory will come back and say, no, we need all these things to be set up in order to be able to provide you with quality data. And then the method choice, ensure that it's fit for purpose. So are you going to use it just for screening? Are you going to use it for confirmatory testing? Are you going to use it for making clinical decisions? That's very important. And then contamination control is a complete non-negotiable, and quality management as well is a complete non-negotiable. So again, making sure that the data that you produce in the lab is connected to action. So making sure that whatever, the data that you get from the sample flows all the way to leading into action. So what we typically say in the laboratory is I want to make sure that when I receive the sample, the data that I report at the end of the sample, everything I do to that sample from the beginning to the end ensures that what I produce at the end is as accurate as possible, a depiction of the exact amount of that analyte in blood. And in this case, it will be lead. So I'm going to post there's a lot packed into a small presentation, but I think we'll benefit more from the discussion, and I'm happy to take the questions at the end of the presentations.
Thank you, Grace. I'll invite our next speaker, Ibu Ayu, who is the head of Research and Center for Public Health and Nutrition at the National Research and Nutrition Agency in Indonesia, and my colleague, Edwin, who is the epidemiologist with Vital Strategies, to share their experience about National Blood Lead Survey in Indonesia. Over to you all.
Good afternoon. Thank you, Yelu. Good afternoon, everyone. First of all, I would like to express my sincere gratitude to the organizer for inviting us to share the Indonesian experience. Before discussing the surveillance system itself, it is important to first understand why this issue has become significant public health concern in Indonesia. Blood lead surveillance is urgent needed in Indonesia for key reasons. Number one is because it reflects the government commitment of Indonesia, strong commitment to strengthen health system by reducing lead exposure. And second, children are particularly vulnerable with an estimated 22.7 million in Indonesia. Children having blood lead level above 5 microgram per deciliter, while no level of lead exposure is considered safe. And number three, surveillance provide an opportunity to generate national evidence on blood lead level, risk factor, and also major source of exposure. Finally, this data essential for developing evidence-based policies, evaluating intervention, and also supporting effective lead poisoning prevention and management across sectors. Therefore, blood lead surveillance is not only a public health activity, but also an important foundation for protecting the future health and development of Indonesia children. This slide illustrates the multi-sectoral collaboration framework from blood lead surveillance in Indonesia. At the national level, the initiative is coordinated by a national technical team involving the Ministry of Health, the National Research Innovation Agency or BRIN, and also the partner such as Vital Strategies and also Pure Earth Indonesia. This slide illustrates the organizational structure of our working group, which successfully integrate both government and non-government partners. The National Technical Team coordinates strategic direction alongside the Ministry of Health, BRIN, Vital Strategies, and also Pure Earth. Our mission is operationalized through three key pillars. Number one, public health surveillance, which flow dynamically from provincial down to district levels, Second, we make a training driven by national experts to continuously build local capacity. And number 3, laboratory capacity, ensuring strong diagnostic support. The entire system integrated directly down to community health posts like Puskesmas and also Posyandu for grassroots reach. Overall, this framework demonstrates that blood-led surveillance is not only a health sector initiative, but a collaborative national effort. Yeah, this slide summarizes the key activity involved in implementing the national blood-led surveillance program in Indonesia. The process began with strong cross-sector coordination and capacity building through the training for Puskesmas health workers and community health workers. After that, community-based recruitment is conducted, followed by informed consent procedure and risk assessment, interview with participating families. For data collections, capillary blood sample are taken using point-of-care devices, while a subset of participants also undergo home environmental assessment to identify potential exposure source. Finally, the results are disseminated to local stakeholders, followed by counseling, follow-up, and case management for affected children and family. Overall, this implementation approach combines community engagement, health system strengthening, and evidence-based follow to support-led exposure prevention in Indonesia.
Okay, thank you. So I will continue the presentation. So this is the one I want to highlight about the objective and also approach. So our surveillance, Indonesia is one of the largest population-based surveillance. So we estimate about blood level prevalence because Indonesia before we don't have kind of like evidence on the exact BLL prevalence based on the primary data collection. And the second one is we want to test the feasibility of our surveillance in the future. So this is a really good opportunity for the government if they want to integrate into health system. And the third one is the most important thing that we want to, kind of like a trigger multi-sectors to do identify the potential risk factors so they can start to work on eliminating the sources. So our methods is we use a cross-sectional study design. So we measure the risk factors and the BLL in the same time, and also based on the WHO STEP survey. So we calculate around 1,600 children, aged 1 to 5 years old, and then we use mentioned by Ibu Wahyu before that we use portable analyzer, and also we use some structured questionnaire, including kind of like a take-home exposure, and also from consumer products, and also some from knowledge attitude practice, something like that. And also, as our previous speakers say, that it's pretty important to know how reliable, how accurate our data. So we use a subset of our samples to be confirmed by using a venous blood to laboratory. And the right top of the slide, you can see that this is our sampling strategy based on our 6 provinces, because Indonesia is a very diverse in geographical area. So we just, after discussion with the Ministry of Health and BRIN, we selected only the major island from Sumatra, Java, and also Bali and Nusa Tenggara. And so we both mix about purposive and also simple random. So this is our overview of our blood levels results. So basically, our result from Indonesia is 1 out of 7 children had an elevated blood level. So this is quite similar with our about the mean. I mean, 2.9 microgram per cent is quite similar with the prediction from IHME in 2021. And although we found that a lot of them are, under 5 micrograms per liter, but we want to emphasize there is no safe level for lead exposure in blood. And because Indonesia has already adopted a WHO national clinical guideline, so this is really important to know how we can implement what the guidelines do. And this is for the some socio-demographic overview. So basically, it's 50-50 among boys and girls, and also for the age group, we can see that some of them mostly are above 3 years old. And for the geographical area or the urbanicity, we see that it's quite half and half. And also for the monthly income, we divide into three levels for the income levels. So for the educational level of the caregivers or parents, so we can see that most of them just completed for the middle school and high school. And the last one is about health insurance. We saw that 18%, some of them doesn't have any health insurance, but this is not really a big deal for Indonesia because we already implemented universal health coverage. And this is the summarize of our factors that we try to see what the potential factors based on our questionnaire. So the risk factor that may have a chance to increase the level of BLLs is the first one is chipping pain, actually. Yeah, the presence of the chipping pain have a 61% higher chance of having BLS above 5. And it's also accompanied by other factors such as the take-home exposure from workplace, and also from the use of the cosmetic powders, and also metallic cookware for cooking. So in opposite, so some protective factors that we also face is about the level of education, and also for the higher income. If you can see from here that our blood level burden are disproportionately higher to low socioeconomic families, actually. So this is what we found. And the next one is about from the urbanicity. This is really maybe a little bit different from other study that in Indonesia, urban area has a lower blood debt level. Maybe we can see what the confounding factors. And the next thing is about the calcium supplementation. So we see that also it gives kind of like a slightly chance of the lower BLLs, although we also stated that calcium supplement should be accompanied by the medical indication. So over to you, Ibu Wahyu.
Yeah, we will continue. The slide is highlight several key policy recommendations to reduce lead exposure and strengthen public health protections. The first, we need to strengthen the health system through a national blood lead level surveillance programs. A stronger surveillance system will help identify high-risk population earlier and support evidence-based intervention. And second, routine monitoring, reporting. While the surveillance framework should follow national standard, the implementation must also adapt to a local context, culture, and community practice. We also learned that engagement local stakeholders, including district health offices, primary health center, local leader, and community health cadres is critical for building trust, improving visibility, increasing community acceptance, especially for sensitive procedures such as blood collections. In addition, operational aspects such as important permit ethical clearance and field coordination need to be anticipated as early as possible to avoid implementation delay. Another important lesson is to integrating blood sampling and counseling into primary health care services help strengthen local capacity and support long-term sustainability. Finally, continuous engagement and dissemination of findings to stakeholders are important to strengthen ownership, relevant and the uptake result for future policy and actions. Okay, this is highlight several key to policy recommendation to reduce lead exposure and strengthen public health. We need to strengthen the health system to a national blood level surveillance program. A stronger surveillance system will help identify high-risk population earlier and support evidence-based intervention. And also, we make routine monitoring, reporting, and rapid intervention for potential sources. Lead exposure must be improved. This is important to prevent exposure before it becomes a larger public health problem. And also, increasing public awareness and knowledge about lead poisoning is essential. Community need better education about the risk, sources of exposure, and preventive action they can take. Finally, reducing lead exposure requires strong multi-sectoral collaboration. The health sector cannot work alone. Partnership between government, industry, environmental agencies, researchers, and communities are critical to creating a sustainable solution. Thank you for your attention. We hope this recommendation can contribute to better policy and healthy community in the future. Thank you.
Thank you. And I will invite our last but not least speaker, Dr. Amalia Laborde. She is a professor of toxicology at the Republican University of Montevideo. She was formerly the director leading the Poison Control Center there, and she has over 20 years working on lead poisoning prevention. And we would like to hear from you the integration of blood lead surveillance into the childcare in Uruguay. Thank you.
Thank you for having me here. I'm really happy to be participating in this meeting. I would like to share how the healthcare sector was involved in Uruguay, and a small country in Latin America and South America. How we start being involved in lead exposure detection or identification, and how the healthcare sector do strategies to start put visible the problem of lead exposure, and how to the health sector start to be in a voice, demanding actions, preventing actions from the health sector, but also from the environmental sector and the city governments. We have publications about lead exposure in Uruguay since 1990. We have a lot of publications that shows that we had a problem with lead exposure in our country, and that was not a problem of other countries. However, lead exposure was recognized as a public health problem after a scandal. You know, after one case motivates the community demand to the public health to study the whole community. In that case was the neighborhood called La Teja. And after being studying more than 400 children on these neighborhoods, we understand that we had many children that were exposed to lead. And in those times, more than 10% had more than 10 micrograms per deciliter, the old reference value in that time. And the government did important actions in order to prevent exposure or future exposures. We banned lead in gasoline in 2004. We lowered the amount of lead in paints. We start regulating the battery recycling that was in that time the main source of exposure, and now it's quite difficult to recycle batteries because you cannot buy a battery if you don't give the battery to the seller. And the Ministry of Health, 9 years after this situation, developed a protocol. And this protocol or guidance to manage the pediatric population according blood levels had an obstacles to working with. That was that it was supposed that we have to manage these cases according blood levels, but nobody asked for blood levels. And so after this time, we working first in the poison center, then in a unit of environmental and occupational toxicology, start to planning with the primary health sector a project of developing some actions in the primary health sector, because we realized that the healthcare sectors needed training to understand lead exposure and poisonings, needed tools to work in the community and in the territory, and also they need access to blood level testings to screen the at-risk populations. And we also learned after this protocol that the health sector or the primary health sector needs some referral service, some support from specialized areas in order to go ahead with these tools and these activities to detect or identify this population at risk. So we started with a partnership between the Toxicology Center, the Occupational Environmental Toxicology Unit of the University Hospital, and the primary care network of the State Health Service Administration. This administration is the public health sector, it's not private. And the project focuses on enhancing the ability of the primary health sector in identify, prevent, diagnosis, and treat exposures to environmental risk in general. But we have the most important program is lead program. I think we are using the former version. Yeah, no problem. Imagine it says lead program of the Pediatric Environmental Unit. And this pediatric and toxicological specialized care are integrated by pediatricians and toxicologists. They complete an environmental history that starts in the primary care setting, and they are able to do blood levels testing with a portable lead curve and the confirmation of atomic absorption spectrometry at the university for levels above 5. And they develop a standardization of medical management, including treatment. And at the primary care actions, we together develop a questionnaire, a local customized questionnaire. We also develop a home and community visits file or checklist. We did some community workshops in order to interact with those who represent the community and also activists in terms of environment. And we do also assessment and monitoring of growth and development, and also comprehensive care, has always in primary care actions. And in both of these pediatric environmental units interact with government bodies, with city government, environmental ministry, etc., in order to assessment and, of course, interventions to stop exposures. This questionnaire has been developed 10 years ago and is still working. 6 out of 10 questions refers to lead, and it was customized according to lessons learned in years before when we recognized this issue, and ask about sources of exposure, but also ask about the knowledge of the population, about lead-exposed people around here in their neighborhood or in the family. The checklist has particularly, we teach with photographies and videos, the main sources we have found in these communities, and look, the checklist look for evidence of e-waste burning areas, backyard accumulation of metallic gadgets, evidence of battery recycling or any metal smelting, evidence of landfills, old paints, car repairs, ceramics, toys, or small lead parts, fishing weights, and so on. And also collect information about environmental monitoring data from this area, and collect information from the agencies or government, local or national government, and also from the community representatives or other sources like research or university studies. And we also have a clinical criteria for suspected severe lead exposure. Of course, it's severe lead exposure because if it is symptomatic, it's severe. But we do not want to lose all these cases that we are sure are there. And actually, we find cases, severe cases. And the actual criteria are anemia, resistance to treatment, chronic or recurring abdominal pain of unknown case or unidentified cause, a result of a neurodevelopmental assessment indicating a risk of delay, of undetermined cause, and acute or insidious encephalopathy, which cause has not been determined. Let's see some of our numbers. I'm sorry, but it's not clear in this version. We have seen 1,500, more than 500 cases, and in between 2011 and 2024. The maximum blood lead level we have registered is 64. The media, the average is 5.3. and more than 10% still have more than 10 micrograms per deciliter. But in general, we can say that 35% of our population assisted is over 5 micrograms per deciliter. And we are still seeing what we learned from scientific studies. The younger the children, the higher the blood levels. So we are insisting and do all these actions, particularly when children are under 5. And with reference to the evolution, in this 5th year groups, we can say that there is a tendency to decrease, but when we analyze this tendency, we find that we still have around 30% of children with more than 5 micrograms per deciliter. So just to remind the importance of the healthcare sector involvement in lead exposure identification and the need that not only it's involved in national vigilance programs, but also in identifying high-risk exposed children. So, thank you. Gracias.
Hi, I'm Audrey Pennington from Vital Strategies. I know that we are running over and we are between you and lunch. So we, in the interest of time, are going to skip questions, but I'm going to ask all the presenters to stay up here. So if anybody has questions, please come forward and ask our presenters. And also, if you're watching virtually, please feel free to reach out by email to follow up. We really appreciate not only the introduction to the bedrock of surveillance, which is in the laboratory, but the discussion of a first surveillance system and then integration into the healthcare system. So our presenters today gave us a lot to think about, and we look forward to continuing these discussions over the next couple days. So thank you.
Thanks very much. Sorry to rush people back from lunch. Delighted to introduce the moderator of our next panel, Akhil Bansal, who's a fellow at the Centre for Global Development, working with our market shaping accelerator. So trying to figure out new technologies and new ways of doing things, including potentially on lead. Akhil, over to you.
Should we give everyone a minute or should we just get started? Yeah. Afternoon, everyone. Thank you for making your way properly back from lunch. My name is Akhil, and thank you, Lee, for the introduction. I'm an infectious disease physician and a policy fellow at the Centre for Global Development. I feel like a bit of a fraud. I'm no lead expert like all of you. I'm much more of a lead amateur. Before I open this session, though, I've spent a lot of my career focusing on an issue called antimicrobial resistance or drug-resistant infections. And it has a lot of analogies with lead. It has a huge burden, particularly in the Global South. Surveillance is an essential component of that. It's also a complex One Health problem, and the solution architecture requires multiple things. You need to align commercial incentives, you need to engage industry, you need to work on policy change. Similar to lead as well, AMR kind of catapulted itself into the global agenda and the global but about a decade ago. So in the mid-2010s, we had hundreds of millions of dollars that poured into antimicrobial resistance. There were big declarations at the UN General Assembly, and large amounts of money were dedicated to AMR, and in particular for surveillance. But despite that significant focus on surveillance, it, a decade later, has not had the desired impact. That surveillance hasn't translated into meaningful changes or reductions in antimicrobial resistance. And so from that, I've learned a lot of lessons, and hopefully through that analogous language, we can discuss how we can best make use of the fantastic surveillance data that is coming out and make sure that it's actionable, leads to change, and it's continually conducted and it's ongoing. I'm delighted to moderate this discussion, to hear about some of the fantastic national surveys that have come out in the last few years. My colleague Theo was telling me before that in the last year, we've had over 20 national-led surveys, which is more than that has happened over the last decade combined. So it's an extremely impressive feat. I'd like to introduce our first speaker to the stage. So our first speaker is Indra Jafikowa. She is an environmental specialist and project manager with more than 2 decades of experience in environmental protection, chemical safety, and public health-related environmental risks in Central Asia. She currently serves as program manager of the Public Association of Equa Bishkek, and she's going to share her work on national blood-lead surveys in children in Kyrgyzstan. Welcome.
Good afternoon to everybody. I'm very pleased and glad to be here and present work which was done in my country. First of all, this map, just to have impression where my country located. It's in Central Asia. We have border with China, Tajikistan, Uzbekistan. It's landlocked country. It's mountain, small country, and it is laying in Pamir and Tian Shan ranges. So until now, there was no information in Kyrgyz Republic of lead poisoning of children in whole country. In September 2024, Minister of Health issued special order to conduct study blood lead level of children, 1372 months, and first results of this BLL testing we had in January 2025, and in February 2025 we had completed home-based assessment. I would like to note that Kyrgyzstan has very strict vertical healthcare system from the Soviet Union, and any intervention related to lead exposure and poisoning can only be done, implemented under patronage or coordination with Ministry of Health. This includes collecting of blood biological samples, environmental testing, treatment, monitoring, and surveillance activity. Thereby, the first step which we did, it was signing memorandum between Ministry of Health, our organization ECOIS as local partner, and our main partner in implementing this project, Pure Earth. And then after that, the second step was to setting up an interministerial working group who is more or less stakeholders of this subject, I mean lead problem. So the study was implemented through intersectoral partnership of government agencies, international organizations like Pure Earth and Vital Strategy, and national NGO ECOIS Bishkek. And it was funded by Takeda Global CSR Program, and all partnership activities in the country was coordinated by our organization ECOIS Bishkek. Our organization was set up 2006, and from that time we implemented more than 30 projects on chemical waste. Mostly it is POPs, persistent organic pollutants, heavy metals, and medical waste. In total, we tested 930 children, and the test was done around the country, and it was in total 18 settlements. A multi-stage random sampling approach ensured representativeness in terms of territorial distribution, settlement types, and socio-ecological characteristics. All these tests was done by capillary blood with the help of lead care equipment analyzer. Venous blood samples were collected from 44 children whose capillary BLL exceed reference level. It's 5 microgram per deciliter, and it is approximately 5% from all tested children. As we don't have equipment laboratory which can do biological materials on lead in our country, we had to send this test to Russia, to Moscow laboratory, and it was done on ICP-MAS. Total 188 households were assessed during our whole-based assessment, and with the help of XRF, and we detected lead in soil, paint, spices, cosmetics, and toys. 188, it's approximately 20% of all households with children who had elevated BLLs. Plus, the parent surveys identified behavioral and household exposure pathways contributing to an increased risk of childhood lead poisoning. In addition, 114 samples of drinking water and soil were analyzed. Again, just to have impression that this test was done around all the country, and these 18 settlements with no known lead-related industry. Why I wrote that no known lead-related sites? Because in our country we have industrial, we'll say, legacy sites, the left after Soviet time with lead tailings. And that settlements, people live next to these tailings, and of course it's clear what can be source of contamination in these areas and these settlements. That is why home-based assessment, we didn't do that settlements. We trained 6 teams on BLL and 1 team on home-based assessment. 6 because we have received, in the frame of project, 6 analyzer lead care and only 1 XRF. But in reality, we did 3 trainings as it's depend on our 3 main partners under the Ministry of Health. The first partner is Republican Center of Health Promotion. Their task was to ensure parents to bring their children to our study for the testing, and to that healthcare facilities where the testing were conducted in accordance with the Ministry of Health. The second agency, Department of Disease Prevention and Sanitary Hygienic Epidemiological Surveillance, they were responsible for implementing home-based assessment and standardized parent questionnaire covering behavior, risk factor, and demographic and exposure sources with the quality control protocol. And all this assessment was done by XRF. And as I said, we detected lead in paint, soil, cookware, cosmetics, and toys in households. And the leader partner in the frame of this project and this study, it was National Institute of Public Health, again under the Ministry of Health. 6 teams on BLL was exact from this institute. They trained on capillary blood collection and operating of the lead care. All these tests was done in primary healthcare level. It's usually family medicine groups, or at least if it is small village, it's felcher midwife stations. I just would like to explain how our vertical is working. We couldn't go somewhere and do some samples. It should be done in healthcare facility. And primary level, it's on the village, it's family medical groups or felcher midwife station. Yeah, some pictures, how this training was organized. The key results, children with BLL higher than 5 microgram per deciliter were identified in all regions, and comprising it's more than 21% of the national sample. The range children who has 3.3 microgram per deciliter, it's 68% children in the country. Age satisfaction showed an increasing proportion of children with elevated BLS as age increased. Different proportions of elevated BLS were determined by gender, and from this table you can see that more than 23% of boys has higher than 5 microgram per deciliter, and more than 18% of girls has higher than 5 microgram per deciliter. If we say about key findings, that it is 1 in 5 children in Kyrgyzstan has elevated blood lead levels. It's above, again, 5 microgram per deciliter. Elevated level were detected in all regions of the country and in 18 populated areas, indicating the systematic nature of the problem. When we just started to this study, we supposed that some far from industrial center mountain villages can be clean. No, we have contamination everywhere in the country. High risk was observed among boys, older children, those living in rural areas, and children from families with low parental education levels. Main source of exposure and risk factors. Home-based assessment data shows high concentrations of lead in paint, cookware, and toys. For example, more than 65% of the tested paint on some surfaces exceeded maximum allowed concentration 5,000 ppm. It's reference level of EPA. Regarding the cookware, more than 37% of all tested cookwares exceeded MAC 100 ppm. These findings allow us to suggest a hypothesis that these factors were associated with elevated BLL. Analysis of questionnaire shows that the following risk factors could be associated with elevated BLL: living near industrial facilities within 1 kilometer, parental work involving lead, it can be some battery manufacturing, metal melting, and smoking in their home, which nearly doubles the risk. I would like to mention that our country just started to work on this problem, lead problem. It's only third year of our lead project with Pure Earth. And in the beginning, we clearly, when we did some focus group meeting and we asked the question, what do you know about lead poisoning? It was absolutely silence. People even didn't understand that it can be a problem. That is why we need a huge of work to do to change mind of the people, not only wide just population, even specialists, doctors, healthcare workers, even. That is why, in the beginning of our project, we did assessment of laboratory capacity. And as I said, we don't have any laboratory in the country which can do biological materials on lead. Yes, we have laboratory which can do environmental samples, water, paint, cosmetic, etc., but nail, urine, hair, no one. Blood. So the task for us, one, was to procure this ICP-MS for the country, and I hope till the autumn we will finally have this equipment in our country, and the next stage of BLL we will be able to do on our own equipment in the country. And you know, most of you scientific and doctor, everything in medical healthcare facilities should be done according to protocol and clinical guidelines. We didn't have such tool, such document in the country, and we finalized developing of this document. And Dr. Anna here from Indonesia, she was our international expert who helped us on it. And now we are on the stage of approval of this document. So after that, we developing training models to train medical healthcare workers, parents, community leaders, people who work with lead as occupation, and after according to rules, these trainings should be approved as well. And I hope till the end of this year we will start to work on training of all these specialists. And after that, and we just started, it was requirement from the Ministry of Health, and it was one of the tasks of our project to set consulting center. It will be on the basis of Public Health Institute. They will do all these trainings online, and we started to equip them with necessary techniques, you know, video classes, trainings to do this. And one of the very important thing is to continue to implement comprehensive public awareness campaign to educate communities about the harmful effects of lead exposure and promote prevalent measures. As a conclusion, I can say that this first national evidence-based assessment of lead burden in Kyrgyzstan confirmed special heterogenetic cumulative lead exposure patterns, the applicability of portable and reference laboratory methods for civilians. This data provide a foundation for in-depth analytical and epidemiological work and expand lab monitoring program in pediatric population. The household surveys sample is not representative. However, it allows for the formulation of several hypotheses that should be confirmed in follow-up studies, such as it is possible that the etiology of lead poisoning in children is associated with paint, metal cookware, and toys. Again, some pictures after visiting our experts from Pure Earth when we visited different agencies of Ministry of Health. So, thank you for your attention.
Thank you so much, Indira. Next, I'd like to welcome Dr. Philip Abel, who's an American pediatrician. He's worked for over a decade with the Keso Gyalpo University of Medical Sciences at Bhutan and is now a research specialist at the Medical Education Center for Research, Innovation and Training. In 2018, he co-led the first pediatric blood lead level study in the two largest cities in Bhutan and provided instrumental expertise for the Bhutan Ministry of Health's National Blood Lead Survey, which he's going to share some of the findings from today. Thank you.
Thank you so much for this opportunity to present. No disclosures to make, and basically, majority, 98% of what I'm presenting is from the national survey, and it's listed there. This was conducted by the Ministry of Health in collaboration with the medical university and outside UN and international partners. So the National Blood Lead Level Survey was a two-stage national survey. It started off in 2023 with a health survey, which included just under 12,000 households. We analyzed the data and found that there was about 3,600 children, 1 to 6 years of age, that we could focus on testing for a national study. While we were focusing on the 1 to 6 year old children in their homes, we also wanted to include mothers that were both pregnant as well as breastfeeding and had delivered in the last 6 months in those homes. And we did propulsive sampling as the two teams were canvassing the country at 17 different monastic institutions. We wanted to get an idea of what children in monastic communities were being exposed to. Because in these national health surveys, they're household-based, and so we have thousands of children and adults in monastic institutions that are not included in these kind of surveys. So in total, the black number on the bottom, the black numbers will be the nationally represented data. The purple numbers are non-nationally represented sampling, but it's good information to see just where we are with our data. So in total, we had just under 3,000 children in our survey. We had about an 81% response rate. And during the survey, we took the household data from the National Health Survey to get demographic data on location, income of the home, and other factors. We asked a long list of risk factor questions from the survey, and Bhutan has a validated developmental screening tool for birth to 5 years of age, and so we used that on the 1 to 5 year old children as we went across collecting this data. So we had two teams of enumerators that took about 2 months to collect the data. The enumerators each had a HemoQ machine that they did blood hemoglobin testing in the home, and at each home they would collect the blood samples in the lead care small containers and brought them back to a central location each evening for testing. Here's the distribution of the population. So the prevalence of lead poisoning, which we defined as 3.5 micrograms per deciliter in the US, was just under 76% across the country. I've always included the 5 microgram cutoff on the bottom also. So we had just over 50% of children in the national sample that had a lead level above 5 micrograms per deciliter. Now, if you look at the distribution across ages and across income, you often would see these levels, percentages dropping off as the children get older. But you can see here that going from 1 year of age all the way to 6 years of age, there's no statistical drop-off, nor is there a drop-off in income, as we typically would see those in the lower income categories having higher exposure. That's not the case in Bhutan. Basically, you have about a 75% chance throughout all income categories. So the prevalence across dzongkhags, or what we other countries might call districts, you can see that the bright red are the highest percentages. The north and the northwest are some of the highest. The areas along the southern border with India have some of the lowest, but 38% in Sarpong in the bottom south is nothing to be proud of when we still are at 38%. And again, these are at 3.5%, or 3.5 micrograms per deciliter. And just to give you, in Thimphu, which is where the capital would be, Paro, the neighboring one where the airport would be, Thimphu, if you look at 5 micrograms per deciliter, we had 67% of kids had a 5 micrograms per deciliter in Thimphu. 88% of children in Paro had a 5 microgram per deciliter or higher. So as we had the information on anemia, this is actually what caused me to question lead in the first place. We have multiple programs for anemia to address it through nutritional programs and supplementation programs. But in all of our studies over the last many years, we've always had in the high 30 to low 40% of children with some level of anemia. So we looked at this data, and again, we found that 38% of children had some form of anemia, and that's adjusted for WHO's definitions based on elevation, because we have huge topography differences across the country. And you can see that as the blood lead level increases from less than 3.5 all the way up to 19.9, you can see that the percentage of children with a blood lead level of 3.5 or higher increases across that timeline. So things that were associated with lead poisoning in Bhutan, obviously the anemia and lead levels were connected. We found that as the lead levels increased, even though we were testing children as low as 1 year of age up to 5 years of age, we noticed problem-solving issues using our screening tool, cognitive domain areas, as well as personal and social issues that were more common in children with the higher lead levels. Risk factors, as in many studies, boys are predominantly exposed. We also had heard of children wearing bullets or spent bullets from firing ranges. That had come up in our first study. And so we asked if any family member had access or exposure to bullets. And you were 1.8 times more likely to have a blood lead level of 5 or higher if someone in your household had access to ammunition, whether it was spent or live. Taking Jinlab Medrib. Jinlab Medrib is a blessed religious substance that we came across just before the start of the national survey. And there was question of whether or not children were given it, if so, how often, as well as traditional medicine. This would not be considered the same. These would be separate areas. And so we asked specific questions, whether or not the child had ever been given Jinlab, if they've ever been given traditional medicine, and if they have, how many times have they been given it and how recently, just to help us understand whether or not this is a true risk factor. And we found that you basically have 1.94 to 2.03 times more likely chance of having a blood lead level of 3.5 or 5 micrograms per deciliter if you are using this. So now, again, this is not nationally represented data, but of the 124 women within the households of the children that we tested, we had just under 60% of the mothers that had a blood lead level of 3.5 or higher, and just under 30% that had a blood lead level of 5 or higher in the study. Among the 207 children in the monastic communities that we tested, we found an even higher level. 86% of children had a 3.5 or higher, and again, 2/3 of them had a 5 microgram per deciliter blood lead level or higher. And this, I will show later here in some slides, that there are some religious items that are connected to lead exposure. So along the way, on a daily basis, when the samples came back to the central location where we used the lead care analyzers, every child that had a blood lead level above 20, or if there wasn't a child with a level of 20 for the day, we sent a team out the following day to the child with the highest lead level. And we were trying to test other family members, parents, other siblings to figure out if this was focused on the child or if there's adults with lead exposure also, and if that would help us understand the source. And so we had 2 teams in total. We tested over 2,400 items in 67 homes. And if the child was an older child that was possibly in a ECCD, crush, daycare facility, or in a school setting, The teams also went to those locations trying to figure out if there was anything in those environments that the child might be exposed to. So this is not a comprehensive list, nor is it nationally represented because we focused on the children with the highest levels. We were just trying to find what potential sources were in this first national survey. And I'm going to focus on the two that are circled in blue because they're very unique to Bhutan and the Buddhist country that I live in. So religious and traditional items, they come in many shapes and forms, from bowls to butter lamps, prayer beads, and the cups that I'll talk about in the bottom right-hand corner. So these items have different amounts of exposure based on how much you would touch, but the prayer beads that are in the center, the top picture actually shows counting beads, which actually get moved as they recite their mantra. And we have found some beads that are pure lead, which has caused issues as far as trying to figure out these are more used by adults, more often by elderly adults. And so how much exposure could there be from parents, grandparents, using their beads throughout the day and taking care of their grandchildren, or cooking in the kitchen if they're not aware that this could be an exposure on their hand that's entering the food. The bottom right, I refer to it as a dasho cup. A dasho is the senior most person, very respected person. Tea is a very big part of our culture, and so you would be served tea many opportunities, and typically the lama, the highest political person, someone very significant in the household, would be given that cup with a beautiful little cover on it. And I can't think of any cup like this that I've tested that has not had lead in the percentage level, more than 10,000 ppms of lead in the paint on these cups. So we have multiple unique sources that we've come across. In addition to these items that you would touch, there's also the item of Jinlab Mendrip that I mentioned. Jinlab Mendrip is a blessed religious substance. Again, this is not traditional medicine. That would be thought of as differently. It can be as smaller than grains of sand, all the way up to over a centimeter in diameter. And you would be given these at religious festivals, at temples, pujas, different activities. And sometimes people would take them right when they're given it. Oftentimes, more traditionally, you'd keep it and hold it until you needed this blessing. You'd soak it in water overnight, and you would get up before sunrise, take it on an empty stomach, and go back to bed for a few hours. So as we were doing the national survey, we asked again how often the child was given these. We also, at the end of the survey, said, would you have a sample of these that you would be willing to give us so we could test? Some of these are so precious and so expensive, people would not even admit that they owned them because they're so valuable. We did collect over 700 samples, and testing them 3 times each with the XRF, we found that over 44% had some level of lead, and you can see that our highest one had almost 6% lead. And so huge risk factor if you're taking these. So based on the questions we asked as far as whether or not children took it, were given it, we found clear information that traditional medicine was very rarely, less than 2% of kids had ever been given traditional medicine. However, 2/3 of children have been given Jinlab Mendrip, and 25% of the children we tested had been given these blessed substances in the last 30 days. So this is a very regular practice across the country. Now, if you look at this, if you look on the far right, those children that had never been given Jinlab, you can see that almost 74% of children still have a lead level of 3.5 or 47% at a 5, having never been given it. So Jinlab is not the only issue that we have. We have many other sources. However, you can see, though, the more times you've been given Jinlab over the last 6 months, your percentage of children with a 3.5 or 5 goes up. We also asked how recently they've taken it. We were just trying to get an idea of how often they've taken it. And if you see, over a 1 to 3 or 4 to 6 month period, the percentage does not increase. But if you get within the half-life of lead of 30 days, those children that have taken it in the last 2 weeks versus the last month, you start to have higher percentages. So in conclusion, lead poisoning, we have found, is pervasive across the country. We have some unique sources, and we have many sources that we still probably haven't even figured out. Additional research is needed both to understand the many sources that we potentially have, because we haven't found one smoking gun, as some of the other countries here have, which I'm kind of jealous of. It would make life a lot easier. And then we need to come up with culturally appropriate, cost-effective, sustainable interventions to address this problem moving forward. Special thank you to the funders of this study, the Ministry of Health, the university, and all the partners that have helped conduct this study and all this work over the last decade or so. Thank you so much.
Thank you so much, Philip. Next, we're going to have Dr. Sabir Haider speak. He's working as a senior scientific officer in the Institute of Epidemiology, Disease Control and Research in Bangladesh. And he led the Multiple Indicator Cluster Survey in 2025, which included lead. Unfortunately, his colleague Hosnain Ahmed, who's a medical doctor and public health professional at UNICEF Bangladesh, is unable to join us today. But he was responsible in UNICEF's technical support team for integrating blood lead into that multiple indicator cluster survey last year. So without further ado, I'll introduce Sabir.
Good afternoon, everyone. Today, if we are talking about our high prevalence of the blood lead level in the mixed survey that we have actually conducted in the 2025. If we look at where the Bangladesh is situated, it is actually in the Southeast Asia. It is one of the very small country, just over 149,000 square kilometer like that, and it is one of the densely populated country in the world. It's more than 170 million people actually are living there. So we have lots of different problems and like that. We are one of the low middle income countries, and heavy metal exposures are actually posing a significant public health problems in the Bangladesh, with the children and the pregnant mothers and others. So if we look at the condition that what is the threat, we all know that the heavy metals during the early 2000s, there was the arsenic problem is huge there. And later we actually identified the sources. We actually come up with the alternative options. And now we actually found that the problem of the arsenic is no more. But the problem of the lead is what is the extent of the problem, so we have to need to identify that. We know that the lead is actually causing a lot of problem in the children, the pregnant mother, the development and growth. The disturbance and in the pregnant mother, it caused that preterm birth, the low birth weights and others. So it causes not only the neurological and others, it is actually affecting all the organs of the person. I think that all of you actually know better than me, actually. And we all know that there is actually no safe limit, that we are continuously talking about that there is no safe limit, but every microgram is the matter. So what is the condition of the Bangladesh? Previously, we have conducted a few studies. One of the studies actually conducted in the 2022, where about 980 children were tested between the 1 and 18 years old. This is mainly actually supported by the UNICEF and conducted the IDCR, where the two actual exposure side, one is the Khulna and another is then actually the Tangail was the exposure sites. And the control side was taking the Sylhet and Patuakhali. In that study, it was found that more than 40% of the children were having a high blood level. That is actually 5 microgram per deciliter. And 70% of those children are living very close to the, the ULAB recycling sites. There's another study that is our ICDW colleagues actually conducted. It is they tested actually around 500 children between the 2 and 4 years old, and they found that their median blood level actually 6.7 microgram per deciliter, and 80% of that had the BLL of the more than 5 microgram. And they found that the 40% of the higher blood level in the children is living within the 2 kilometer of the lead polluting industries. And they also found some contributing factors like their smoking in the households, household members in the related industries, and the children using the amulets. I think that we call that the traditional things. That the nail polish and other, and also the high lead household dust. And there are also the few other more studies, but we have the many isolated studies, but we didn't have that, not a nationally representative any studies, but we need how the nation actually, what the reason, national estimates is going up. So there is that we have conducted, the mixed multiple indicator cluster survey. We all know that it is actually a very big survey. It is conducted around 125 country or the territories. It is the mix actually identified around 172 indicators, and 27 are from the SDG goals. Previously, it is actually round 7 that was conducted in the last year, 2025. It is previously all the study was, this survey was conducted by the Bangladesh Bureau of Statistics, which is under the Department of the Statistics. But this time, actually, it is actually, if we want to know that what is the status of the blood lead level, so that both the Department of the Health, the IDCR, and ICDDR, all are actually collaborated. So it is, we can say that it's a multi-stakeholder actually initiative. So in this survey, there was a two-stage stratified sampling was conducted, and about 3,149 clusters, and more than, you can see that 62,980 households were visited. So it is a national, but we have another thing is that we have 2 special region, that is that FDMN, we call that forcibly displaced Myanmar nationals, that we all know that as a Rohingya population. So there was the 94, that the cluster was there. So in total, actually 3,243. So these 2 FDMN population lived, one is in the Teknaf and another is an isolated island that is Bhasanchar. So our team were actually conducted that. The target population is 1 to 4 years of age, and also the pregnant women. In the one cluster, one pregnant mother from the one household, if identified, that is eligible for the blood collection, and 1 children from the one household, that is if identified, then it is actually eligible for the blood collections. So all the venous blood samples were collected for the testing, and these were all are done in the 2025. So it's a very big survey. You can see that there were actually 43 teams conducted nationwide, and it's every team have 9 members. So it's an BBS. The statistics department have that 7 team members, and 2 of from the IDCR or the Ministry of Health is there. We have one of the phlebotomist and the porter. So one of the key challenges is to actually the preservation of the sample and maintaining the temperature at the field level. So we used actually both the cold box. When they're actually going for the sample collection, they use the cold box and maintaining 2 to 8 degree centigrade temperature. And every day they came back to their sites, and they actually have the dry shippers there, and they put all those samples in the dry shippers, which is that it's a minus 180. And every weekend, all the dry shippers, the 43 teams came from the different corner of the Bangladesh to the IDCR, the central level, and they actually deposit all the samples and then actually liquid nitrogen actually refill and then again go back. So this is the way actually we collected those samples every week, and it happens for the 4 months in the last year. And all these samples were actually tested in the ICP-MS. So what is the results? If we can go see as a very quick, see that we actually 3,243 sample, the clusters in their 16,536 children were actually eligible for that. But from the national level, that we estimated two actually different. One is 10,667 children were collected blood, and we collected 957 from the FDMN population. And for the pregnant mother, 2,591 is actually eligible for the blood collection, but we collected the 2,099 population. Around that 1,934 from the national and only 165 from the FDMN population. So collection rate is very, that is good, especially for the FDMN population, but the national level is actually very acceptable that we actually collected all those things. If we can see the what is the status of the children at the 12 to 59 months, the urban and rural have not such a difference, but still the urban is a higher rate of the urban population is actually more having high level of the blood level, and the richest quintile also suffer the most. And the Dhaka, actually, that is the capital of the Bangladesh, and the Dhaka, that division, actually, we have the 8th division, and 65% of the children of the Dhaka division is actually have more than 5 microgram per deciliter. So it's a huge number of the children are affected. So, if we can see that this is actually detection level of the threshold. In the overall 38.34% our children are affected, that have the high blood level than nationally. We tested other 3 heavy metal also, the cadmium, arsenic, and mercury, which is actually 3.82% children have the higher level. Only 1.27% of the children have high level of the arsenic and very small of the mercury. Now I come to the pregnant mother. We can see that here also same that the urban having a high level of the urban pregnant mother is actually suffered most. Around 14% of the pregnant mother is having a high blood level. And here is also the richest quintile is more affected. And Dhaka is again having the more, 23% of the pregnant mother, and the Dhaka is actually having the high blood level. So if we see that the what is in the pregnant mother status, the overall around 7.54% of the pregnant mother is having the high blood level, and only 3.32% is having the cadmium, and 1.62% of the mother are having the arsenic, above the threshold level. If we see the division-wise, you can see that 8 division, Dhaka is the most, 65% of the children and 22.8% of the pregnant mother is having a high BLL. Next followed by the Sylhet, and also after that the Chittagong, all have a very high BLL. If we see in the map, you can see that in the geographic region, the Dhaka having when we consider that more than 5 microgram per DL, the Dhaka is more than 50% of the Dhaka division is that we just showed in the table that is graphically representative. But if we can actually see that how much is the more than 10, it is in the Dhaka division, we have found that the more than 10% actually in the Dhaka division, the children are actually affected having the high BLL. above the 10 microgram per DL. So in the Dhaka city, it is a very crowded city. It is more than 25 million population is there. It is barely any place actually. It is not only the population, it is one of the densely populated city, and we have that more than 50,000, around 50,000 population per square kilometer. So you can understand that how dense it is. And not only the population, actually, presently we are seeing for the last couple of years that we have a large number of the battery-led actually rickshaws, actually previously or paddled, they are actually coming up into the Dhaka. So it is also the highly concentrated of the battery-led rickshaws in Dhaka. So this is the status of the Dhaka city. So you can see that in the Dhaka, 91.5% of the children having excess of the high BLL. So Dhaka is again divided into the two city corporations. One is the Dhaka South City Corporation as the North City Corporation. In the Dhaka South City Corporation, around 50% of the children, I mean the 49%, having the more than 10 microgram per deciliter. So nearly half of the children of the Dhaka South is actually having a more than 10. And in the Dhaka North, 60% is falling under 5 to 10, and overall, this is also very high BLL. And if we consider that, you can see that 41% is lies of the children is lying between the 5 to 10. Again, 41% is 10 to 20, 41.5%, and more than 20% of BLL is, the children are affected by the more than 20 microgram per DL. And we found that one children is having around 70 microgram per DL, so that is a very high. So in the pregnant mother, the 61% of the pregnant women with a high BLL level in the Dhaka South City Corporation. So this is actually our first nationwide measurement. We have that mix is for the first time in the Bangladesh is conducted, and we found that it is overall the scenario is very alarming. The children and both the high proportion of children and pregnant mother is having the high BLL. Though the urban and the wealth-based exposure is having both the richest quintile, and especially the Dhaka is a very a vulnerable condition. So to identify, so now we have actually the status of the children and pregnant mother. Now we have to find the source. What is the source of that? So we actually conducted the market survey is going on, and we are planning for actually doing that after that household survey, and also to conduct the follow-up survey, the farm food survey, and we also need that treatment center of the lead poisoning, because we found that there are lots of children and the pregnant mother is affected. So we need a treatment center, and also need the national guidelines, and those are also going on, and hopefully. So it is, I mentioned earlier that nowadays we found that a lots of battery rickshaw is there. We just noticed the few outbreaks of the battery recycling plant. I mean that related with the recycling plant in the last year. Many actually the animals and the poultry are actually died there. So we investigated that those things. So we have to create awareness to prevent those things. Actually, I mean to under the strict rules and guidelines. We have also the paint, lots of, in the different studies, we found that the lots of paint containing the lead, the cosmetics and other lead exposure that should be reduced. One of the good things is that we now have a national strategy and action plan that actually said that we have to be a lead-free Bangladesh by 2035. We hope that we can do that, but we have to go many works to do that. And our project actually is planning to build a capacity for the national level to raise the, actually, it is between the, it is also multi-sectoral, the Department of Environment and the Ministry of Health actually having a their joint project to actually build the capacity of the our national level. So at the end, I can say that we have to do the awareness and advocacy, the source identification and the public health protection and lots of things. At present, Bangladesh is facing one of the devastating outbreak of the measles now. It is in the last few months, we have more than 500 children actually died and thousands of children are affected in the measles. So everyone is concerning about that. So it is not only the measles, that ladies also have a very high concern. So it is have a chronic effect and other things. So this study, hope that the policymakers and others will take into actions to take this study into account, and they will take appropriate measures to actually reduce all those, the exposures and others, so that we can minimize all those actions. Thank you. That's all from me. And last of all, sorry, I didn't mention that this is supported by the UNICEF Bangladesh and also the Bangladesh Bureau of Statistics, and supported all well. And thank you to the ICDDRB and others who actually all doing this, supported this study in a very good way. Thank you all.
And lastly, can I please welcome Jenna Forsyth to the podium. She spent the last more than a decade working on lead exposure. She currently oversees Project Unleaded, an initiative at Stanford's Wood Institute that focuses on identifying and mitigating priority sources of lead poisoning globally. Her team did some landmark work on turmeric in Bangladesh, and she's going to present the work on turmeric consumption in India today. I ask after Jenna speaks if our three speakers, and we'll all jump on stage and we'll take a quick few questions.
All right, thank you so much, everyone. Wonderful to be here. Great to hear the other presenters' findings. Really interesting and important work. So, as was mentioned, I'll be discussing our work in India, actually, around turmeric. And, spices have been known as a source of lead exposure for some time. Lead and spices have actually been linked to elevated blood lead levels in several countries. So Bangladesh is one of them. In India, the state of Bihar is another area, the Republic of Georgia, as well as some cases even in the United States. There are multiple types of spices that can have elevated lead, especially those orange to yellow hued spices, so turmeric, especially in South Asia, as well as marigold flower and marigold flower spice-based mixes in the Republic of Georgia. There are other spices with elevated lead levels as well, but to a lesser extent. So those include chili, cumin, mango powders, and cinnamon, to name a few. So why India? Well, India has a large burden of lead exposure generally, among the top 3 most lead-burdened countries, but it's also the world's leading exporter and consumer of spices globally. We've done some work on supply chain studies that show that lead chromate pigments, the bright yellow pigment, is being added to the turmeric roots to increase their color, but also extend their shelf life. And this particular study was motivated by our market sampling study. So we had looked at over 100 of the most populous cities across India. We had selected and tested samples of multiple spice types, and we actually found from that only turmeric had elevated lead above the national limit, and that the roots had most of the lead and not the powders. Interestingly, it was across 10 of the 23 states we tested that had high levels of lead. So this was surprising because it showed a much bigger geographic extent than we were initially thinking. But of course, it was a market-based study, and it's really hard in these informal, loose in bazaars and marketplaces to understand the market share. So we were left with this question of whether or not and to what extent there was a lot of household exposure of turmeric, and particularly these dried turmeric roots. So we conducted this study in partnership with ID Insight. We have colleagues in the room here. The sample was 1,200 households in each of these 10 states that had previous evidence of lead chromate adulteration at the market level. And we conducted this between August last year and February this year. This was a multi-stage stratified random sample. So our primary sampling unit were districts. These were selected with a probability of being selected proportional to their population. And we had secondary and tertiary sampling units, including the sub-districts and the polling stations and the census wards in these rural and urban locations. We were also able to generalize these findings beyond their households to over 170 million households using, by using survey weights that were calibrated to the latest National Family Health Survey. So in terms of our data collection and analysis, we collected samples of turmeric, and we asked specifically for those households to provide samples of turmeric used for cooking. We analyzed these samples with a calibrated XRF, so an X-ray fluorescence analyzer, calibrated specifically for turmeric powder and turmeric roots separately. And we sent a subset of these samples to a laboratory to confirm and for validation. We asked questions at each household as well. We wanted to understand turmeric consumption and sourcing patterns. We also wanted to understand the quantity of turmeric being consumed at these households, and generally their perceptions about impure turmeric. We've done some analyses, so basic descriptive statistics as well as spatial analyses. We are also doing some ongoing modeling of estimated blood lead levels, and you'll see a glimpse of that here. So this is what it looks like in terms of the districts where we sampled, between 10 to 29 districts across those 10 states, and you can see them shaded in this map. And in terms of our participants and the household characteristics, overall we had 12,072 households who participated. The average household size was a little over 5. I won't read out all of these details, but just to say that 99% of the respondents were reporting consuming turmeric for cooking. So not too surprising. We knew that it was common for daily consumption across South Asia, but that confirmed this. Our kind of top-level finding, consistent with expectations, that Bihar had the highest prevalence of elevated lead in turmeric. So we're using that 10 microgram per gram national limit as a reference point here. And 33% of households in Bihar had elevated lead in turmeric. This was followed by Karnataka and a few other states you can see, Madhya Pradesh, Uttar Pradesh, Jharkhand, and Chhattisgarh. And then the 4 remaining states where we had elevated lead in turmeric from the market study actually kind of fell to the bottom of our list. We saw kind of 3 tiers here, Bihar at the top with this next cadre of those 5, and those 4 at the lowest levels. On the right panel, you'll see the comparison between the market survey and the household survey. And what we saw is that the market survey overestimated prevalence for those lower prevalence states, but was pretty similar for Bihar. It also, both the first and second most highest prevalence states were similar for the market and household surveys, so that was Bihar and then Karnataka. In terms of the forms of roots with elevated lead, we found that dried turmeric roots were the riskiest. 24% of those samples had elevated lead. Interestingly, 2.5% of the packaged turmeric powder, so these are brands that are recognized by the government, sold on a larger scale, those had elevated lead as well. The consumption patterns mirrored some of this, so Bihar had the highest rate of reporting that their primary source of turmeric used for cooking on a daily basis were dried turmeric roots. This was followed by Uttar Pradesh and Madhya Pradesh. So now looking at this divided by the states and a little more spatially, you can see some patterns here. Again, the most, this is a spatial heat map actually showing the prevalence of lead in turmeric of these different forms. So again, Bihar with the highest proportion with dried roots. But interestingly, with the loose powder, Karnataka actually had higher lead in loose powder than dried roots. That'll become important in a subsequent slide too, so you can remember that. When it comes to perceptions about impure turmeric, 1/3 of households reported having a high level of concern about impure turmeric. But interestingly, they had a misaligned risk perception. So they're actually much more concerned about ground turmeric powder on a whole than they were about dried turmeric roots that were seen as more pure. Now, when we subdivide that again by states, this is where it's a little bit interesting. Karnataka, remember, it had a higher proportion of lead in the loose turmeric powder, but they have this flipped risk perception, actually, where they are more concerned about dried roots than loose powder. All of the other states had that the other way around. So Bihar, where the form of turmeric that's the riskiest is the dried roots, actually they were most concerned about the loose powder. So it's a really interesting point. It becomes important as well because when you look at 2 samples of turmeric, especially, so take a look at these 2 samples of turmeric powder. Can anyone see a difference here? This is, the one on the right is 100 times higher than the national limit would say is allowable. The one on the left is lead-free. It's really hard to see a difference in the loose turmeric powder. But when we look at the dried turmeric roots, again, that lead chromate is kind of painted on. It's literally the lead paint painted on these turmeric roots. You can start to see a little bit of a difference. It's not perfect. You can see on the left, the far left panel and the left panel on the leaded turmeric side, it's a little more stark, the contrast. But on the right-hand side, you can see that the well-polished turmeric roots have an orangey hue, and then the turmeric roots that are polished with lead chromate have the brighter kind of canary yellow look to them. We had our analysts actually blind the lead status. We had our analysts look at the turmeric roots and tell us before we analyzed them with the XRF if they thought they were above or below the national limit. We did a little bit of basic training, just a couple of PowerPoint slides to show them some examples, in hand. They were correct 3 out of 4 times. So that's really helpful when you think about this misaligned risk perception. It's not perfect, but again, it's a start. So I won't get into depth on estimated child blood level increases. We know that if you're eating the turmeric root with the lead, you're going to get exposed, unfortunately. There are case studies in the US where children, age 2, consuming lead and turmeric at these levels had 48 micrograms per deciliter of lead in their blood. So it can be really high. It's not surprising. We are working on some kind of Monte Carlo simulations to look at how this looks across this larger population. But just to give you a glimpse of the most conservative estimate for children under 5 who've been eating or eating turmeric from their homes on the kind of geometric mean, or the average level of lead in that turmeric for 1 month, you can see that again, lots of details here, but just taking a look at the bolded section, on average, the geometric mean in turmeric root for those with adulterated turmeric was almost 278 micrograms per gram. The estimated lead intake on a daily basis would be about 153 micrograms per gram, taking it into account about 43% bioaccessibility. And that would result in about a 3 microgram per deciliter blood lead level increase just from turmeric alone. When you look at women of reproductive age or adults, this is increased by a factor of 3 to 4. So along these lines, on just kind of an average basis, that represents over 5 million children with that situation. But when you look at this scale and you extrapolate it more across this population, across children, over 5 million children consuming adulterated turmeric, over 20 million women of reproductive age, and the remainder other adults, it's over 59 million people affected. So this survey is really helpful in clarifying this. And when we look at the different states, again, over 35 million people in Bihar alone. This is a really important place to make progress here, and there has been incremental progress over the past couple of years, and there will be more. But from a population standpoint, Uttar Pradesh comes in second at that population estimate, again, because of the higher population, even though the prevalence is slightly lower than Karnataka, but then Karnataka third. And we see the other states following. Madhya Pradesh quite close, Jharkhand, Chhattisgarh, and then those other 4 quite a bit lower. So this was really helpful for us to prioritize where to focus on intervention. Really happy to have so many partners in the room. So folks from Pure Earth, LEAP, and Poly India Foundation, we're working together to put these findings into action. Of course, you can see that misaligned risk perception is really important and really actionable. So that's a key focus area for consumers. I think that could be very important in India, but also just making that more clear among other people in industry and in the government. And then, of course, targeted policy enforcement. We've seen, in the case of Bangladesh, a coordinated enforcement drive can make a big difference in reducing lead in turmeric, and so I think there's a lot of promise for that to work here, too. So thank you so much to our funders, Coefficient Giving, and Stanford King Center on Global Development, and our partner, ID Insight, for this.
Can I ask our other speakers to come onto the stage as well? We have about 10 minutes for questions, so I'm going to ask that you keep your questions brief, but please do introduce who you are at the start of them. Would anyone like to start with a question in the front here? Yes.
Is it working? Thank you. Howard Hu, University of Southern California. And some of you know I've been a physician epidemiologist doing lead research for a long time. I'm really thrilled by this conference and also this presentation. And I just wanted to ask first a question. How many people here are clinicians? So the point I wanted to make is that clinicians have very little understanding of this problem. And I think that point was already made once. But when you're talking about monitoring and surveillance, the United States, for a long time, required pediatricians to take a blood level for any child between the ages of 6 months and 5 years. Those blood leads went to a laboratory that had to report them. That's how we got national statistics on top of the NHANES study. Wouldn't that be a way, is that a way in countries where monitoring that needs to anticipate what will happen once all these programs are done and you figure out levels of lead exposure, could we use that monitoring systems through pediatricians requiring to test children as a way of surveilling the efficacy of the programs going forward?
Would anyone like to take that question? Do we have a microphone by chance? Thanks, Theo.
Thank you for the question. In Kyrgyzstan, this issue under the discussion. For now, we just started to construct this system, monitoring system, in the frame of Ministry of Health. We just started to develop clinical guideline, just started to develop the models. We'll do some trainings, but in the clinical guideline, it is they drop some algorithm which department or agencies of the Ministry of Health what should do step by step. And one of the tasks to do the systematic regular monitoring. Of course, we don't have enough money for this. For now, we don't have absolutely the money. All the work was done on the money of the donors. But it's the task, it's the aim for the country to finally have this own monitoring system, as own system. And for example, I talked with donors and my partner from Pure Earth to support +2 studies. It's cost effectiveness and capability of the children, because Ministry of Health need evidence to go during the meeting of the government and demand money from the national budget, from the Ministry of Finance. It's a big problem. We need and we have to do this. And that is why it's very important. Okay, we just started to do it. I hope that finally we will have this system in our country.
So for Bhutan, the desire is to have a surveillance system. A lot of it just takes time to build the laboratory capacity and to get the resources to get to that level. But we hope more data will be coming out of Bhutan in the very near future.
Why don't we take another question? There was a woman over here with the glasses on her head.
Good afternoon, Dr. Safina Abdullaeva from UNICEF based in Pakistan. Thank you for a wonderful presentation and my question to Bangladesh. I have been working in Bangladesh as well. So you presented that the higher level of lead in blood was found among richer population in Dhaka. Could you elaborate on it? What are the possible exposure pathways for riches? Because it's unusual, right? It's normally the other way around. So I'm just interested to know about this. Thank you.
Thank you. Thank you. It's a very nice question, actually. We see that in the Dhaka, very high BLL level among the children and the pregnant mother also. So what is the source and others? So regarding the source, we are doing, actually we conducted, recently we conducted the market survey in the Dhaka division with the high, the South City Corporation, and which have the very low, so we can actually compare those things. And in the coming months, we have planning to do a household survey. So that the source identification, we can actually properly answer all those your question after those survey which you conducted. Because we'll go to all those children's home and we'll identify all those sources. So at the present, we just identified what is the status of the blood level. But regarding the source, what we can see that we found that the children toys are having a very highly contaminated, and also this is maybe one of the key sources actually. So let's come to the other service result come, then I can will actually truly give you the full results. Thank you.
We might be cheeky and try and get one or two more questions in. Is it Tammy? Yeah.
Hi, Tammy from Lead Research for Action. Really interesting presentations. I was really curious to see, it was really interesting to see how a lot of the blood lead level data is presented as like percentage above 3.5, percentage above 5, percentage above 10. And I know that these are like international national reference levels that have been set by WHO, CDC, etc. But I'm really curious to know whether any analysis of the distributions, because obviously blood levels are continuous, so wondering whether there was any analysis into the distribution beyond just these binary cutoffs, and whether that reveals any other patterns about sources, and like whether certain sources are predominantly more common in households above 10 or above 5 or above 3.5, and if we're missing anything by looking at this binary measure rather than treating blood levels as continuous.
So in Bhutan, the data that I presented, those are the highest children. So they would be often over a blood lead level above 20 or the highest one for the day. So unfortunately, we did not have the data to compare those households that had, say, a 3.5 or even a low on lead care, below 3.3. So definitely requires more study to figure out if there's a difference. We just have such a huge problem right now. More study will be needed to try to find those differences.
Maybe one last question. There's a gentleman over there with his hand up. He's standing up just in the middle there, yeah.
Thank you. This is Mahbub from Bangladesh. I have one question, and just to supplement a little bit, the Dr. Sabbit that responded to Dhaka findings, just to briefly tell that found from the Dhaka studies that the children living near the lead and lead-related industries, they had the high blood lead level. And for the Dhaka South City Corporation, especially dense, and the most of the industries in this area. So we found that these areas basically highly contaminated. And my question is to Bhutan colleagues, it's really great presentation and the great work. I thought earlier that Bhutan is much better than any other countries, but still see the situation. But can you explain a little bit more what is the key factor for contributing this high blood lead level in Bhutan? Probably I have missed, but still if you can supplement on this. Thank you.
Thanks for the question. If I had that answer, I'd be happy. Right now, we have multiple small sources. We don't have the turmeric that's a huge problem that we can say, let's change this and see what the outcome is. As of now, we have multiple sources, potential sources. We have lots of aluminum pots that have lead contamination in them. We have very little paint. We have some toys. We have some spices. We have some religious items. I'm sure we're going to find more. I wish I could say we have found the one thing that we can change and get half of the results we want. But as of now, more study is needed.
Fantastic. We might close the session there. I'm just going to hand back to Lee, who will tell us what we are expected to have next. Thank you so much, Lee.
Great. Thanks very much to all of our speakers. We have 15 minutes, so go grab a coffee, grab a break, and then we'll be back in here at 4:05 sharp for the next session. Thanks. Welcome to our last session of the day. My colleague Pete Baker is going to be moderating our last panel, who's a fellow at the Center for Global Development as well and acting director of our health program. Pete.
Good afternoon, everyone. Great, thanks everyone for joining. Lee, thank you very much. Thanks to everyone that's organised. So yes, I'm Pete Baker. I'm a fellow and acting director of the health programme here, and I'm very excited for this to be moderating this particular session because I think it takes us nicely into some positive solutions and ideas for solutions, which is a really nice place to move I think the lead agenda. So I won't spend any more time myself in the session. I just want to immediately move over to our first speaker, Jyoti Yadav, who's the Assistant Director and Fellow from the PAL India Foundation, and she'll be talking about blood levels, neurocognitive outcomes in Indian children, a multi-country study. And we'll go one by one through 4 speakers, and then we'll have a chance for Q&A. So Jyoti, come have a seat.
Thank you. Good evening, all. Okay. So my presentation is on assessment of blood lead levels in the pediatric population and its effect on the cognitive and the mental health. This is a study which, like from the Indian perspective, when we try to see it, we see that 1 in 3 children exceed basically the safe BLL thresholds. And then when we see the pool blood BLL, that is thrice the CDC reference level. So that is around 10.4 microdeciliter. And then when we see the IQ levels here, so it's approximately or about 4 IQ points. That is the average intelligence loss that is per child due to the lead exposure. So that's the lead emergency of India, and that's the global, which I think all of us are talking about this. And when we talk about the aim and the objective of this study, which we are doing it, so we are trying to see the prevalence of the BLL in the Indian pediatric population, that is from the age group 0 to 18 years. And this is across the 7 aims representing 7 geographical regions. 7 aims I'll talk about. This is the All India Institute of Medical Sciences. And along with this, we are also identifying the quantification of social demographic risk factors, that is the age, sex, SES, parental occupations, and the resident types. We are also mapping the environmental determinants, that is the proximity to industries, the household lead sources, that the paint, the surmas, the kajal, which we're talking about it. And then we are also doing the assessment of psychiatristic and the cognitive status, that is the WISC-4 in children with elevated BLL. That is including IQ, attention, and the executive function and behavioral domains. Now, there was a meta-analysis study done by ICMR and IOH, that is the Indian Council of Medical Research. This is where the 51 studies have been done. So when we see the gaps in the existing literature, there is no geographical representation. So we see that all the 51 prior studies were single city or single state. So when we look at the India, there are 28 states. So this is a single state study. And no study has ever captured north or the other zones which we try to see it. So that is why we have tried to come up with all the 7 aims together. And there is no standardized analytical method. So we are doing the ICPMS testing here, where all the 7 aims are doing together. There is no cognitive outcome data on, I'll say, the IQ levels or the intelligence level, which is losing the children's IQ there. And then there is no multi-specialty team approach. So these studies were particularly led by one particular department and not the several departments there. And no neonatal focus. This is the very first study in India where we are doing the cord blood testing of the children, which is the 0 newborn children's there. So we see this is going to be the study at a glance. We are seeing it that around 12,740 testings has to be done. So this is the biggest study in India, which we are doing it in the age group of 0 to 18 years. And then 7 AIM center from different parts of India, which has come together. So we're testing that. And then per center, I'll talk about this later on, I think. So first, nationwide coverage. So there is no, we just talked about it, there is no prior study which has achieved this geographical spread in India as, I'll say, the children's-led research in India particularly. And then the scale is around 12,440 students. And last, which I'll talk about the equity first design, because when we try to see India's structure and the geographical representation, this is the oversampling of the low income, the peri-industrial and the tribal communities. So that means we are ensuring that the data represents India's most vulnerable children, not just urban hospital attendees, because these are the 7 aims which are also present in tribal areas, then rural areas. I'll just show you the geography. So when we look at the study design, it's a mixed, that is the community and the hospital-based approach. In the community, we are going to the schools. So we are testing children from the 6 to 18 years of age group. When it comes to the hospital, the second part, we are doing the 0 to 5-year age group. So that means the cord blood is also collected at the hospital, which the children are born at the AIM center particularly. I'll just talk about it. So when in the hospital we are doing it, we're also testing the pediatric workshop, that is the CBC, the LFT, the KFT, the iron, ferritin, and the DIBC. So these are the other parameters which we are also testing along with the BLL. And along with this, I think this is where the standardized protocols have been maintained across all the 7 parts of the country. So these are the, I think, a geographical map which shows which part of India we are testing it. So different aims. So there are particularly around 20 AIM centers in India, out of which 7 centers we are testing. So AIMS Nagpur, that is the central India. So different zones, we are covering different zones according to the ICMR and IOH meta-analysis. So we are covering, so I was just talking about that, we're covering all the low income, all the different industrial belts, the tribal communities, the agriculture chemicals. So we're trying to cover all the exposure contents from different parts of the different geographical regions here. This is the sample size. So around 6 to 18 years of the community which we are doing it. We are testing 6,370, which is the largest. And also a lot of testings has been done in the 6 to 18 years of age group. But when it comes to preschool, that is 0 to 5 years. this is where the gap is there, because none of them have tested the cord blood or the 0 to 5 years. So we are covering that as well, and that is also the around 6,370. So around per center, we are testing 1,800 samples per center, and there are 7 particular centers. This is the methodology we're talking about. So from sample collection to cognitive assessment, across 7 aims, different aims, because 7 different aims, particularly they are the public institutions, so they work according to them. So this is why we try to form I'll say the particular that all the protocols are same for all the 7 centers. So sample collection protocol is same. That is why we're doing how much blood has to be collected, where it has to be stored. So once the blood is collected at each center, they are transported to one center, that is the AIIMS Nagpur for testing. So all the testing has to be done on one testing center so that there is no preoccupations or the testing facilities, different centers are. So we're just doing this parallelly so that all the 7 aims parallelly are collecting the blood samples. Second is the ICPMS. So at one center only, there is one ICPMS. There we are testing all the samples. So the transportation is done from all the different six centers to one different center, that is the AIIMS Nagpur. And then exposure and risk factor mapping. So we are validating a questionnaire along with the blood BLLs and environmental samples. So once we have the test results from these, then the environmental samples with the high blood lead levels would be tested. That would be the dust, the water, the paint, the spices, or the other environmental samples. After this, the maternal BLL test for all the neonates with the elevated cord blood would be tested, and the anthropotic and the clinical assessment. That is the height, weight, BP, anemia, and all that screening would be. And then last is the cognitive and the psychiatric assessment. I think this is the most important part of our study where we are testing the WISC-4. So all the psychiatrists are using this WISC-4 through which we are administering this. And then the full domains of all the intelligence, the comprehensive, the IQ scales has been tested. And then I just talked about the different additional tests, the CBC, and all this would be tested along with this. Another part, which I think was a gap in the earlier studies, which we have tried to come up with this, that a different network of expertise. Earlier, one faculty per center used to have only one faculty. Now in every centers, we have 6 different, per departments we are working, from biochemistry to psychiatry to pediatric. So all of them have come together. So when we say that 6 heads per center into 7 centers. So this is how all the faculties from different aims from the public infrastructure has come together. And this is the expected outcomes and the deliverables, because right now we are in the process of collecting the blood lead levels, because it also includes the schools, which has limitations because of the summer vacations and all this. So this is, I think, taking a more of time. But we have approximately 4,000 samples we have collected, and then by next 2-3 months, we will collect the blood samples, and then the testing would happen parallelly at the one center. So this is going to be the primary deliverable. So the national blood lead level prevalence map. So first ever state or the region-wise prevalence of the blood lead level across 7 different geographical regions would be done. Then the risk factor profile of all the, the samples would be done. Cognitive impact evidence, because we are linking the data to the BLL with the IQ levels or the WISC-4 data here. And then the neonatal lead burden. This is the major important part where the cord blood BLL across 7 cities, 7 different centers revealing the utero or the lead transfer in the maternal exposure patterns would be tested. So this is, I think the study would be completed in the month of September this year, and then the testing is happening parallelly. So by the end of September, we'll have the testings, results, and everything done by this. These are a few of the snippets which are from the field, which is happening at different parts of the country, so different 7 regions. And this is the significance or the novelty and the policy impact which is going to create it here. So we are going to have a policy impact for this. First ever PAN study, first ICP-MS only because all the testing through this, first BLL and the WISC for, I'll say, the integration or the cognitive impacts formally measured in the same cohort, because earlier 51 studies has different regions, smaller sample size. I think this is the biggest, largest, and the sample size we are covering in India, because this is where the lot of data gaps in India exist. So this is going to cover that. Plus, it happens from the AIMS Institute, which is a public institute. So I think this is going to create a lot of, on the government also, on the governmental side also, this is going to create a lot of data so that the policy implications can take place. Thank you so much. And I think I'd like to thank all my 7 partners and the coefficient giving for this. Thank you so much.
Thanks, Jyoti. Okay, can I invite my next guest, speaker, Rebecca Margalit-Chan from Cornell University, who's going to talk about the beneficial impact of secondary lead interventions on children's outcomes.
Hi, everyone. Thank you so much for having me. I'm so honored to be here, and I'm so excited to present our work. My name is Rebecca Margalit-Chan, and I'm a graduate student. I'm obtaining my PhD in economics at Cornell University. Today, I will be presenting our work, The Beneficial Impact of Secondary Lead Interventions on Children's Educational Outcomes. This is joint work with people all over the country, from Brandeis University to the United States Environmental Protection Agency, Appalachian State University, the US Federal Reserve, and the University of Notre Dame. I'm also extremely thankful to the Children's Environmental Health Initiative, who has provided us with this data set. So, as a couple of presenters up here have mentioned, there is no safe threshold for lead. Even low levels of childhood exposure can still create cognitive deficits and behavioral issues, and these persist into adulthood. It should also be noted that children who have higher blood lead levels also tend to be more likely to be in poverty and more likely to be minorities. So this inequity in lead exposure widens the already systemic achievement gaps that persist. And finally, in the United States, there are actually still around 500 to 600,000 children who live in homes that there exists some kind of lead hazard. But it's not all bad news. The United States has had some very great legislation that took place in the 1970s, 80s, and 90s. This included the Clean Air Act, as well as the Safe Drinking Water Act. So leaded gasoline has been banned. Leaded paint in residential homes has also been outlawed. And plumbing standards, so piping and water quality, have also had increased standards. So together, these 3 regulations have been extremely effective. And there's been a 96% drop from 1976 to 1980 levels of childhood blood lead. So 1976 to 1980, the average blood lead level for a child was around 15 micrograms per deciliter. Today, it's about 0.6, sorry. And currently, today in the United States, the primary exposure source for lead is aviation gasoline, and it's currently being phased out. Regulations are underway. These are all well studied. These are preventative measures. But what about after a child has already been exposed to lead? There's a little bit less known about that. These types of secondary interventions can include property investigation to determine the source of the lead. They can include, nutritional counseling, especially for calcium and iron, because lead can be stored in your bones or in your brain for a developing child if you're deficient in calcium or iron, as well as counseling and guidance to remove the source of the lead, so remediation after the source has been found. But for these types of interventions, randomized controlled trials are often unethical. If you have a child who you know has already been exposed to lead, it's fairly unethical to put them in the control group and withdraw or withhold some kind of treatment that you know could be helpful for them. So there are few and far between randomized controlled trials, And those that do exist often offer the control group also some kind of intervention, which makes getting the identification of that treatment effect really difficult. So this is where this study comes in. We have about 20 years of birth records from the state of North Carolina. These are individual level administrative data sets. In addition to birth records, we also have blood lead surveillance. I think it was Howard Hu that mentioned that there's systemic testing. So children under 5 years old are required to get lead tested, especially if you are on Medicaid or some type of financial assistance. So we have all of the lead test surveillance records from 1992 to 2015. We also have linked those to education records. So every every school in North Carolina has provided us with their math and reading test scores, in addition with other variables, but math and reading test scores are what we're going to focus on today. And finally, we have the property investigation data set. So this includes information on whether or not a child actually underwent remediation. So in particular, this is the information on intervention. So this intervention in particular had that property investigation. It came with nutritional counseling. And if the source of the lead was identified, it would also be remediated. And so from this data set, we can tell who received the intervention, whether a source of lead was identified, whether remediation was required, and if it was remediated, if the residents got cleared. Now, that is a smaller sample of children. It's 5,648 children. And after we match them to the birth and the blood and the lead data, we end up with a sample of 2,154 children. Because again, this is a sample of children that have elevated blood levels. Now, elevated blood levels, blood lead levels, I'm going to define as 10 micrograms per deciliter. And what makes this policy easy for us to identify a treatment effect is actually their eligibility requirements. So to be eligible for this program, a child had to have 2 confirmed elevated blood lead levels. So on the x-axis here, we have their second elevated blood lead test. So anyone who had everyone in the sample had at least 1 test that was above 10. On the x-axis, it's our second test. So if you were an 8 or a 9, or a 10, 11, or a 12. On the y-axis, we have the rate of intervention take-up. So in economics, we're going to call this a discontinuity design, and that's because of this threshold at 10. So if you had 1 blood lead test that was 10, and then you had a second one that is an 8 or a 9, you would be in the control group. You would not be eligible for the intervention. But if you had 2 tests above 10, so one that was 10 and then another that was 10 or 11 or 12, you're going to be considered in the treatment group, and about 60% of eligible children actually took up the intervention. Now, because all of these children had at least 1 elevated above 10 micrograms per deciliter test, we think that these 2 groups of children are actually fairly similar. If your second test was just below the threshold versus if your second test was just above the threshold, we're going to call that almost as good as random. And that's going to justify our ability to estimate a causal effect of this program, because nothing else is really changing between these 2 groups of children other than the fact that one of them was eligible to receive the intervention and the other group was not. Now, as I mentioned, only about 60% of eligible children took up the program. This also actually presents us with an opportunity to answer 2 different research questions. So first of all, we can answer, what is the effect of eligibility of the intervention? Because it's probably not likely that policymakers are going to be able to implement some kind of policy where it's mandatory to have someone from the Department of Health to come into your home and investigate for lead. So we're able to answer an important research question here of what is the effect of a policy where it's offered, this type of intervention is offered. But because we can see which children actually receive the intervention, We can also answer the question, what is the effect for children that actually take it up? And here's what we find. So in the group where we're pooling all of the children together, both those that received the intervention and those that did not, but they're above the cutoff, so on the right-hand side of the prior graph that I showed with the discontinuity, when we compare those to children who were not quite eligible, we find that there is a 3.4 percentile point increase in math scores and a 2.5 percentile point increase in reading scores. And when I say percentile point, I should mention that we ranked all of the children in terms of their math and reading scores. So when I say percentile, I'm talking about in comparison to your peers in the same grade in the same year. Now, when we look at just the children that actually received the intervention, we find that those effects are stronger. We find that students who actually took up the intervention compared to students who were just almost eligible had a 5.7 percentile point increase in their math scores and a 4.2 percentile point increase in their reading scores in 3rd through 8th grade. So this is years after they had their elevated blood lead test and potentially also years after they had the intervention. How large is this in the context of other educational interventions? So I'm going to take our strongest scores, the math percentile point scores for children who actually received the intervention. And when we compare that to this Tennessee STAR program, which is a popular and well-celebrated educational intervention in the United States, where they decreased class sizes by 7 students, the effect of that study was 6.5 points. So this intervention is less than 1 percentile point less effective than that intervention. When we compare this to a high-quality preschool, it's actually more effective on average than that, by about 1 percentile point. We can also put this into the context of long-term gains. So again, using this 5.7 percentile point increase in math scores, this translates to a 0.2 standard deviation increase. Now, also using other educational research, we're going to say that a 0.2 standard deviation increase in your math scores, and again, this is every year, 3rd through 8th grade, this translates to approximately 15% higher adult earnings. And when we think about the fact that there's an approximate 1.09 million net present value of lifetime earnings, a 15% increase in that is $167,000. That is about 1/2 of a median home in North Carolina, or about 3 times the median salary in North Carolina. So at an intervention cost of $10,000 to $12,000 per child, this is highly cost effective. It also addresses equity because this disproportionately benefits children who are more likely to be in poverty, more likely to be minorities. So this can be seen as a form of environmental social justice. That being said, even though it is highly effective, there is still room for improvement, given that approximately 40% of eligible families did not participate. In conclusion, for researchers, the discontinuity here, where children just below the cutoff did not receive the treatment and children just above the cutoff were eligible to receive the treatment, this is what allowed us to estimate a causal impact of this intervention. For policymakers and implementers, the North Carolina Department of Health and Human Services intervention here is a really great example of an effective secondary intervention. That being said, there is room for improvement, especially with the compliance gap. So this could be helpful in terms of outreach, establishing trust with the government agency, or even requiring more effective, requiring landlords to remediate more effectively. And Still, over 20 US states have similar programs that operate at this like elevated BLL threshold of 10 micrograms per deciliter. And for funders, these secondary interventions prove very benefit cost effective, so they are worth funding. Thank you so much. If you would like the draft of this paper, please reach out, or you have any questions, I would be happy to hear from you. Thank you so much.
Thanks very much, Rebecca. Really nice, I think, example of both a robust methodology but addressing a really pertinent policy question. So I really love that one. So, Julian, up you come. Thank you very much. Julian Rees is the CEO of Hoppo Therapeutics, if I've got that right, talking about the development of an oral chelating agent. Over to you.
Great, thank you so much. So it's my pleasure to be here and tell you a little bit this afternoon about some of our work developing Hoppo 101, which is an oral chelating agent that we believe could be an exciting and potentially novel treatment for lead poisoning. So quickly before I get going, I am affiliated with Hoppo Therapeutics. We are a for-profit company, so just want to note that as a disclosure. Some of the data I'm going to show are preliminary and have not been peer-reviewed, and also an important funding acknowledgement. Some of the work I'm going to tell you about was done in partnership with the U.S. Department of Health and Human Services, the Biomedical Advanced Research and Development Authority. Okay, so I want to talk about mitigating lead poisoning beyond primary prevention. So this kind of dovetails nicely into something that Rebecca said about what happens after exposure, right? So there are interventions that kind of include things like remediation of lead from home, nutrition programs, things of that nature. But there's also this question of like, what do you do for the now patient, right? Somebody who has lead poisoning, what do you do for the patient? And this is a really hard thing at the moment. So right now, really the only practical way to treat someone who has been exposed to heavy metals, whatever they may be, is with a chelating agent, which is basically a molecule that is designed to tightly bind to metal ions and essentially facilitate their excretion from the body through the formation of these very stable inert chemical complexes that the body will then kind of recognize and eliminate much faster than would ordinarily happen without such an intervention. And so this is really the only approach if you're trying to get rid of metals that are in the human body. And so kind of the schematic I'm showing here is like, basically what we're expecting to happen in the body. So we try and capture this heavy metal with one of these chelating agents, and then the body will just kind of eliminate it. So right now, there are some chelating agents that are available. I think about this as the existing landscape of treatments. So the first on the top here is a drug called Suxamer, which is an oral product that is given, as many of you probably know, in the event of lead poisoning, at least in the United States, typically over 45 microgram per deciliter. So that's what's on the drug label. So Suxamer is indicated for pediatric patients with lead poisoning above 45 microgram per deciliter. There are some safety and toxicity concerns with the use of Suxamer, in particular neutropenia, hepatic toxicity, and because of that, its usage and also the treatment course is very tightly limited. It's tightly controlled. Because I think from a provider standpoint, there's always this question of what is the risk versus what is the benefit of any drug product. Right, and so I think in this case, the benefits for a child who has a blood lead above 45 microgram per deciliter typically outweigh the risks of Suxamer, but the risks of Suxamer are real. Similarly, one of the other commonly used chelating agents is EDTA, or edetate calcium disodium. It's also a similar indication, although typically used in more acute cases, so a medical emergency. Also has some I guess, concerns or warnings associated with its use. Typically, this has to do with its selectivity for heavy metals like lead. And so one of the known issues with EDTA and a lot of other chelators is that they also remove physiologically essential mineral ions, things like zinc. And so you really have to be careful about extended use of these chelating agents so you don't end up with, with zincuria or some other, treatment-induced condition. And so really it boils down to kind of the risk-benefit profile of these existing chelators really limits their use to only severe cases of lead poisoning. All right, so we set out many years ago now to develop HOPO 101 as an oral chelating agent. The original use case for this product is actually in nuclear and radiological disaster preparedness. And so basically what we were trying to do was develop a product that could remove heavy metals like uranium or plutonium from the body in the event of some nuclear disaster. So think of like a dirty bomb, for example. And so because of this, the use case is generally going to be in a low resource setting. So care in a disaster scenario is very, very challenging. The logistics are challenging. You put first responders in harm's way if you're talking about radiological contamination. And so this product was really designed with the goal of being safe and efficacious and self-administered. And so generally that means that an oral administration route is preferred. And so these same things actually make it an ideal chelator in some respects for something like lead poisoning. And so that was kind of part of what led us to this, this avenue of research. So going back to the kind of radiological disaster preparedness use for just a moment, HOPO 101 has significant technical improvements over the standard of care, which is a chelating agent called DTPA, which does not work very well for lead. And so DTPA, similar to EDTA, is often given by IV infusion. And so this means that you really need to have healthcare providers present. You need to have kind of a much higher level of care, continuous monitoring for, again, these physiologically essential ions when you use DTPA. And so what we found throughout extensive studies in animal models for things like plutonium contamination is that HOPO 101 outperforms DTPA by virtually every measure. And so in this case, we're looking at the gray bars on this chart here represent the amount of heavy metal contained in the body of an animal. And so on the left, you see the negative control group. On the second from the left is the calcium DTPA, so this is our positive control. And then the two groups on the right where you see that really big red bar, that's excretion of plutonium in feces. And so we see vastly reduced body burden of plutonium through the use of this chelating agent. And so this was very, very promising and actually led to the award of a significant contract from BARDA, as I mentioned at the beginning of the talk, to develop this product into a medical countermeasure that can be used in the event of a nuclear disaster. And so this is the type of product that governments around the world might consider stockpiling, basically to have on hand should they need it. Now, one of the really interesting things for us, because obviously, we all hope that this is a use case that never actually comes to fruition, is can we expand the utility of this chelating agent to lead? And so the first thing that we did was we looked at the in vitro binding data for HOPO 101 for lead. And so I'm showing the yellow bar that has the binding affinity, the log beta, which is basically the kind of thermodynamic stability constant for the metal complex, is indicated by that vertical arrow. And so we believed that, that this measure was sufficiently high so as to justify us continuing to look at addressing lead poisoning in an animal model using this chelator. And so we put together a study design to assess efficacy in a mouse model whereby we inject lead intravenously into a mouse, and then we administer our oral chelating agent to the mouse by oral gavage. And so I'm just providing some of the details of the study here for those that are interested. This was a 7-day course of treatment. We included a negative control and succimer as a positive control as kind of the comparable oral product. And then we analyzed the cage contents so that the cages that the mice are living in. We can actually analyze the bedding for lead as well as the kind of the carcass and selected organs of the mouse. So we analyzed this by ICP-OES. And so what we found was that HOPO 101 enhances elimination of lead in a mouse model. It's primarily, as we saw with the plutonium data on the earlier slide, it's primarily in feces. And so let me walk you through kind of going from left to right, kind of the major, I'm going to just walk away from the podium here. So kind of the left and right panels of this figure represent days 1 through 4 and days 5 through 9 of the study. And so throughout, basically we see the majority of lead eliminated during that day 1 through 4 window. And the increase in feces, again shown here in red, the increase in lead elimination in feces is indicative to us that we are having a pharmacodynamic effect, right? So that HOPO 101 is promoting the elimination of lead through feces. And this is exactly what we hope to see, that we can actually see an effect of this drug in an in vivo model in addition to in vitro. What we also found is there were a couple of issues with this study. Namely, the placebo animals actually excrete a large amount of the lead that they were administered. One of the other issues is that the biomarker for lead in a clinical setting is blood lead. It's not lead excreted in feces. And so there are some challenges with translating a model like this to a clinical study. The reality is that rodents are just simply not a good model for this type of disease. And so we really have to ask the question, okay, what does it look like to think about evaluating HOPO 101 for lead poisoning in a clinical setting rather than with an animal model? And so we are on our way. So we're in the middle of our phase 1 safety program for HOPO 101, so in healthy volunteers. So we wrapped up our first in human phase 1 safety study at the end of 2025. And I'm showing here an interim readout from this study. So cohorts 1 through 5 of this study. And the pharmacokinetics data on the right here basically is a representation of how much drug has entered the bloodstream. So this is important for an oral product. So we're really interested in basically the dose dependence, which you can see is actually really beautiful PK data here. And also kind of being able to achieve concentrations of the drug in blood that are sufficiently high that we might be able to actually bind the lead that's in the bloodstream. And so the schematic, the design for the study is shown here on the left. Again, I'm only showing data from cohorts 1 through 5, but the data from cohort 6 and 7 I've kind of projected out for you because we can't show them yet. One of the other things that was great to see in this study is that we had no meaningful safety signals in this study. The highest dose cohorts did experience some GI irritation. This is not uncommon at all. And this GI irritation was transient and resolved without intervention. So this is a very, very positive outcome from a first-in-human study. So what I've done here kind of is transform the data that we were just looking at in context of no longer nanogram per mil of blood, but actually in terms of concentration in micromolar. And the reason that I've done this is because one of the things we need to ask ourselves is, are we getting enough drug into the bloodstream to be able to bind the lead that's present? And so the red dashed lines here on the figure represent essentially the micromolar equivalent of the numbers that we're probably more comfortable with, right? So 45 microgram per deciliter at that highest red bar is a concentration of about 2.2 micromolar. And so the question is, can we achieve a high enough concentration of HOPO 101 in blood to be able to bind all of that lead? And I think what I've done for you here is basically project out what we anticipate based on the dose escalation that we've seen in our phase 1 results so far. And so we are quite confident that in these higher dose cohorts, we can exceed lead concentrations in blood of kind of that 45 microgram per deciliter threshold. So this is extremely promising for us in terms of what we believe we might be able to address with this novel chelator. And I'll remind you that I think that we've been able to demonstrate that the safety profile of this drug product is, I think, has significant advantages over other chelating agents that are available today. And so we believe that when you combine the positive safety profile with the pharmacodynamic effect that we were able to show in mice, with kind of this expected concentration of drug in blood, we think that this very much warrants a discussion with the FDA regarding beginning to move into kind of phase 2 clinical development for this product and evaluating the efficacy of HOPO 101 in actual patients rather than just in healthy volunteers. So just want to acknowledge the folks that worked on this study. We have a phenomenal team at HOPO, some really great partners, advisors, and then the study team that actually did the work in the lab on this program. And thank you very much for your attention, and look forward to your questions after the next talk.
Some very exciting, promising results. Thanks, Julian. Anna, do you come up now, please? Anna Navas-Achian is the Professor and Chair of Environmental Health Sciences at Columbia. Going to be talking about trends in blood levels and cardiovascular disease mortality.
Wonderful.
Thanks.
Thank you so much. And I am presenting this work on behalf of Irene Martinez Morata, who could not join us today. And it's a real honor to be part of this panel. And I think the data is going to be collectively really interesting. So as you can see, we are going to leverage the NHANES database, which has been very important for the lead field in general, globally. And if you look, and we've talked in this panel about neurotoxicity, IQ, children, and the other health endpoint that is extremely relevant for lead is cardiovascular disease, and which is particularly relevant for adult populations. And that body of evidence is very well known through epidemiological studies, toxicological studies, and the very intriguing parallel trends in the United States between rates of cardiovascular disease and how they parallel with blood lead levels going down. And unfortunately, we don't have surveillance data for blood lead levels going up. But you can all imagine that with growing traffic patterns, lead use in gasoline, etc., that blood lead levels very, very likely went in parallel. And actually, the peak year, 1968, was both the peak year for rates of cardiovascular disease as well as for lead production in the United States. So that has always been extremely intriguing. And the data available so far from NHANES was able to leverage those late 80s through early 2000s. And those studies have shown that 22%, around a quarter of the cardiovascular disease epidemic, could be explained by declines in blood lead levels. So this is very substantial, and this goes in parallel with the estimates from the burden of disease done by the different entities, World Bank, HMI, and showing that this could be a very, very important health outcome for cardiovascular disease. So the reason why we work on that project was because previous studies in NHANES have been quite short time frame, rather than leveraging the whole richness of the very, very powerful database. The different cohorts and sections of the survey had some complexity that required harmonization, putting things together, making sure they were comparable, and then also analyzing the data in ways that are useful for policy. I think that was very clear also in the way our previous presenters, both the work in India as well as the work on UK IQ in the United States, trying to really think of how to present the data in ways that is useful for policymakers. So we wanted to look both at changes in blood lead levels over time, as well as the connection with cardiovascular disease, leveraging the whole richness of blood lead data in NHANES, which started in NHANES 2 in the late 70s, and until 2020, the latest data that we had available when we ran this analysis. So the trends, I think you all know what happened in the United States. I showed that slide at the very beginning. But it's really amazing to see this figure. And when you look at the data that was presented earlier this morning, the data that presented in India, and I want to point that we are showing the levels in micrograms per liter instead of microgram per deciliter. So you will need to divide by 10 to compare to the data that has been presented throughout the panel. The reason why we did this is because this is the most recent recommendation for us to use micrograms per liter. Microgram per deciliter was used because people were really afraid with the huge levels that populations had around the world for a toxic element that had absolutely zero need to be in the body. The levels were very high compared to cadmium, nickel, any other toxic element that you could measure in the body. And for that reason, it became practice to divide by 10, use it in deciliter, rather than use it in the micrograms per liter. That is like all the other metals are reported in blood. And toxic element, I want to clarify. So, but you can see the huge change from the 70s to the 2020. I also want to say that it seems that things have not declined as much in recent years. However, that's an optic issue because the levels were so high earlier on. If you look, now this is by gender, if you look at in the zoom in the square at the top, we are zooming in between 2000 and 2020. You can see that things have continued to decline. Lead exposure in the United States has continued to decline at the national level, surveillance data. Of course, there are lots of pockets that's still in trouble, but on average at the national level, things have continued to improve, which is really amazing, and it's really thanks to the huge public health efforts that are going on across the country. There has always been this gap, you can see it persist, between men and women. Males are exposed to higher levels in general and also seem to have higher levels in blood and accumulate higher levels than females. We can talk about that. That could be like, we could have a full session. Marcela Tamayo over there, she's an expert in this women's and lead. So we could, one day we need to have, a panel on that topic. The other interesting thing is the differences by race, ethnicity. This has been described earlier. Rebecca mentioned this. If you go to the 70s, you can actually see that white people had higher levels than the green line. The green line, for instance, had the Hispanic that were classified as other. While in recent years, the green line is above the white populations. That was also related to lots of issues going on in the 70s with leaded gasoline, who had a car versus who didn't, et cetera, et cetera. So very interesting trends and changes that we are not totally aware because I don't think those things have really analyzed well at a nation level. So lots of things to go in depth to these socioeconomic disparities over time that continued here with income. And again, you can see that the low income is the green line. You can see that in the 70s, the green line was below the high and the medium income, probably because of who had a car, who had more exposed to leaded gasoline, while in more recent years, the green line has been on top since the 2000s, but in more recent years, those inequalities have declined also. I believe because the huge efforts that have been done in urban settings, housing improvements, huge public health benefit from interventions. Smoking status remains a major source, and smokers are always going to have higher levels. But they've also improved because the environmental improvements have also benefited smokers. So if we look at these snapshots from the NHANES, we can see again in adults, if you compare, we have overall, the top line is the geometric mean, and then the second line is the change over time. 94% reduction in adults compared to 96% reduction in children that was mentioned by Rebecca. Children and adults, all ages, all race ethnic groups, smokers, everybody has improved and declined dramatically. And if you look at the different groups, these reductions have happened, but the differences between different characteristics have changed over time. For instance, the differences between males and females have actually declined. There is now a 25% difference between a 42% difference. The ethnic differences, race, ethnicity differences have declined. Again, that's really good news. By age, the differences have increased. There is much higher difference now by age, and this is probably because of the legacy of past exposures in bone that now remain a very important source of endogenous source for blood lead levels. While in the past decades, in the 70s, the current airborne exposure was so huge that age was less important. And the smoking status remains almost the same. So in general, these data show that both environmental as well as lifestyle factors are important, but I would argue the environmental are, relatively speaking, more important. Public health interventions have been successful, but there are still some inequalities and needs, and especially this is national data, not pockets of problematic at-risk populations. If we look at the relationship now with cardiovascular disease, with as much data as it's available, connecting with the mortality data, we can see if I am going to show you the results grouped in 3 decades, the 80s to 90s, the 90s, and late 90s to early end of 2008, and then from 2009 to 2018. And we've modeled lead by quartiles, as well as per doubling of the dose. A doubling of the dose means going from 5 to 10 or 10 to 20, et cetera. And this is based on very strong data showing of this log linear relationship, this supralinear relationship, and the fact that at lower levels, there seems to be like a higher risk. You can see that the quartiles are slightly different because the levels, the cutoffs are different for each survey. But the doubling is going to be kind of equivalent. You can do it for all the surveys. When you look, I am sorry because I think in the transfer of the slides from my computer to the system, there is some changes in the last column. But adjustment doesn't really change much, adjustment for other cardiovascular disease risk factors or other potential confounders. And what is most important is that no matter in which decade you are, blood lead levels remain still associated with increased risk for cardiovascular disease. And this goes to this fact that there is no safe lead level, at least at the levels that we have today, which are still historically very high compared to what humans were exposed 1,500 years ago. These exposure levels, we think they are low, but this is because we are lacking perspective. So at these levels, in the most recent NHANES, lead remains associated with cardiovascular disease. And this is the dose response curve, where you can see we plot lead in the log scale. So you can see it's linear in the log scale, supporting this log linear relationship. Regarding this, trying to do the data as relevant as possible. So this is the attributable deaths per 1,000 individuals at different cutoffs of blood lead levels. And you can see again that no matter in which decade we are, it's around 12 deaths are at 5 micrograms per liter, 10 of 1,000 deaths are attributable to lead levels. This is actually quite substantial for that relatively. This is 5 micrograms per liter. That's a very low level, 0.5 micrograms per deciliter, to keep you the perspective. 35 is 3.5. And there we have like 20 attributable deaths. If we manage to change everybody from 35 and make it go to 5, so anybody who has 3.5 micrograms per deciliter, if we manage to switch that population and put it at 0.5, really much lower, we would have an improvement of 8.3, like almost 10 cases that we would remove. So again, these numbers are very big. If you look at any other cardiovascular risk factor, you don't even get that. Lipids, other BMI. This is really one of the most dramatic risk factors that we can have in the cardiovascular disease world. And then this was assuming a follow-up of 10 years. If you assume a follow-up of 20 years, this is even more dramatic. So the key takeaways is that historically in the US, we've had dramatic declines in blood lead levels. I would argue that the environmental contributions is really what explain the most. There are still some other lifestyles and other differences by sex and other things, but really the environmental has been the major factor thanks to public health interventions. The exposure with cardiovascular disease mortality remains, and the toxicity is present at below the reference values that we have today. And this dose response seems to be very consistent, no matter in which decade we are. And their estimates are really, when you go into the attributable risk, it's substantial, one of the top risk factors. So I am going to switch now and give you like 3 minutes of a presentation that tomorrow we'll have a little bit more time to go on. And this follows very nicely Julian's chelation presentation. There is a chelating agent that Julian presented earlier, is EDTA, has some limitations because it's intravenous. You need to give it through intravenous infusion. Has some risk if you are not careful in the way you administer it, but it's actually extremely safe. And you don't really feel anything. You get the infusion, you feel really very well. You wake up, you get up, out, you can do all normal life immediately. And so there was a clinical trial of EDTA for prevention of cardiovascular disease in people who already had an MI. This trial, the first TACT trial done by Tony Lamas, was published in 2013 in JAMA. And what the study found is a substantial benefit. It has a ratio of 0.82 for the people who receive EDTA chelation, the red line. So a clear benefit compared to the placebo chelation. So that supported in principle that there could be some clinical benefit for reducing maybe blood lead levels, but we didn't know if the effect was through reducing blood lead levels or through something else, because EDTA, as mentioned before, is a non-specific chelator. The study didn't collect any blood samples, so they could not really measure lead or any other mechanisms for the potential benefit. So the FDA said that these people didn't necessarily have lead poisoning. They were just normal people who had had an MI across the United States. So their levels were likely very similar to the enhanced levels at the time when the study was done. The FDA said one single trial could not be used for approving the treatment. So a new trial was done. This is TACT-2. I had the privilege to serve as the chair for the biorepository for the trial. We collected blood samples now, and we were able to measure the effect of the treatment on lead levels. This is what happens with blood lead levels. It's in the red line. You have a 60% reduction in blood lead levels, quite a substantial effect. By receiving this infusion weekly, and at the 5th infusion, this is like around a month. Half-life of lead in blood is like a month. So you can see that you get actually the most benefit happens then. You still see a benefit by infusion 20, around 6 months, continue to decline. These dots are medians and interquartile ranges, the bars. And by infusion 40, that is around a year, no more substantial benefits. All the lead that you could really mobilize out from your body is out. The treatment stopped at infusion 40. Any of you who know about lead, you can think probably this blood lead level went back up. You started mobilizing them again. It's very possible. What happened with the trial, this is the placebo. Look, 54 months since randomization, more than 4 years of follow-up, when the treatment was only done for a year. So the benefit, the hazard ratio was 0.93. This was disappointing in a way. It didn't confirm the initial trial. At the same time, 0.83 and 0.93, maybe it was similar. It was consistent with each other. Maybe this is still consistent with a public health benefit, not with a clinical treatment, but maybe a public health benefit. We've run more new analyses that you are going to have like the opportunity to look. This is one of the first times. This is the second time that we show them in public, so this is very exciting. This was done by the biostatistician leading the trial with the PhD student, Zheng Lin. So what we've done, instead of using the full follow-up, so many years of follow-ups when the treatment was only done for a year, is to cut all data after 18 months. Both TACT, the first TACT and the second TACT. And the reason also because the trials were not done equally in terms of the length of the administration. I could talk for a long time about this. I am going to go fast. But when you do that, and you compare the first TACT with the second TACT, they are remarkably equal now. There is a clear benefit. The hazard ratio actually looks better in the second TACT. It's 0.76, supporting a benefit consistent with the 60% reduction in blood lead levels that we know happen during that year of the treatment. So this is very encouraging. One of the problems is that the statistical power is very limited. It's a small sample size. The number of events are limited. But from a public health perspective, this feels very reassuring because all the NHANE studies have lots of issues with confounding and other problems. This is a real clinical trial with real randomization. If instead of doing these 18 months and cutting everybody the same, we just go to the last infusion. Some people quit their infusions. Some people took longer. Everybody did a little bit different. Humans, we are not so good. And so we do the last infusion plus 30 days. We see a similar kind of beneficial effect. Again, supporting that removing lead from blood is beneficial. So EDTA reduced lead, blood lead levels. There was no safety issues. I would not say this is of clinical relevance, but this is, I believe, of public health relevance and supports that reducing blood lead levels is beneficial for cardiovascular disease. And in general, these are important data from a public health perspective. There's still inequalities that we need to address. But these historical blood lead levels in the US are consistent with current exposure levels in other countries, supporting that we really need to work really hard collectively to reduce blood lead in general globally. So I think with this, thank you to Irene and Annie Nigra and the rest of the team for doing this work.
Thanks very much, Anna. Very inspiring. We had two for the price of one there, I think, with two inspiring results. Can I ask the panel all now, sorry, Anna, to come back up? If you come around here and through onto the seats, and then we can get some audience questions. It doesn't matter. Yeah. Great. Who would like to go first? I think we have two people roving mics. So there's a gentleman here, and then a lady in the middle over here, please.
Hello,
yes.
I'm...
in the middle, yes, here. Yes.
Hi. I'm Tim Pye from the Lead Exposure and Poisoning Prevention Alliance in the UK.
We can't quite hear you, sorry. Can you put...
Yeah, is that better?
Great, and if there's a particular member you want to...
Well, actually, no, this is a question for everybody.
Okay.
Has anybody ever seen a study comparing exposure to all adverse outcomes for lead? Now, has anybody in the room seen we've picked out here educational outcomes, cardiovascular outcomes. What about everything?
Nice. Let's do the few questions together, please.
Thank you very much. I am from BirdLife International. I work on vulture conservation in Southern Africa, and we found that vultures are greatly impacted by lead from ammunition, which is used to shoot carcasses. We've also found that cheetah is also affected in exactly the same manner, and leopard. We suspect that maybe lions are also affected in the same manner. So mainly my work is on conserving the vultures. We did a study last year that showed that vultures are worth $1.8 billion a year to Southern Africa in terms of the ecosystem services that they provide. My question then is to Julian. We are trying to save every vulture that we can from this because they are suffering from kidney failure, they are having soft eggs, they're having paralyzed chicks. Do you think we could use HOPO 101 to save the adult birds that we are finding poisoned? Because obviously there's nothing, I don't know if there's anything that we can do with the paralyzed chicks, but definitely for the adult birds. Thank you.
Great, so let's do those two first. Can I take kind of moderator's prerogative of adding one thing, because it's going to Julian? Have you taken the implications of that last Anna study to heart as a company? Like you offer an oral option, which could be actually treating myocardial infarction or preventing the next myocardial infarction. So I guess two questions for you then. Vultures, but also would you prevent future myocardial? Are you looking into that?
Yeah, I'll speak to the vultures first. The short answer is I think this is possible. We actually see a similar thing in the United States with other large large birds, bald eagles, California condor. It's quite common actually for them to die of lead poisoning for the exact same reason. It's lead shot in carrion. So we certainly hope so. Is the short answer. Still trying to understand kind of the opportunities in veterinary medicine, which is not something we have much expertise in. And then to your question about the implications of the TACT and TACT2 results, absolutely. I think that the opportunity to think about reducing risk or reducing mortality even of cardiovascular disease through what is ideally and hopefully a relatively simple intervention, and one that can again be an oral product that doesn't require visits to an infusion center or something like that. It's extremely exciting for us. Obviously engagement with the regulators in the United States and other countries is super important when you think about what a trial would need to look like, because as Anna mentioned, when you go to ask for approval of a new drug for a specific indication, it's really important to know ahead of time how much work you have, in order to kind of meet the burden of proof for the regulators. But very much on our radar.
Fantastic. And then does anyone have an answer to the question of all outcomes?
I am happy to answer. Can you hear me when I talk? Yeah. Wonderful. I think, for instance, in NHANES, a number of health outcomes have been looked at, and other studies, maybe not a single study that has looked at everything, but there are many studies that have looked at multiple things. For instance, with the paper that Bruce Lamphere and I was myself involved, that we try to really look at all the different health endpoints. For instance, yes, NHANES has looked at chronic kidney disease, cardiovascular disease, outcomes in children, hematological outcomes. So all of that, we can see them, characterize them really well. I would argue that the health endpoint that seems to be less relevant for lead, at least in general, is cancer. The evidence for carcinogenicity is not clear for lead as compared to cadmium or arsenic, that are very well-known carcinogens. And actually, when you go to the old literature in the 1920s, it was allowed to go into gasoline because with whatever assays they had at the time, they said this is not going to cause cancer. And that was one argument that was used. So I would say, yeah, we know, maybe not in a single study, but collectively there is very good, strong data. Yeah.
And Jyoti, has there been ideas of expanding the outcomes that you measure in your study?
Yes, particularly, because right now we're just doing the BLL first and then do the environmental and the different perspectives. Once we have the result from this, then, because this is the biggest study of the India right now, none of the studies has taken large sample size of the children, which particularly talks about the BLL. So a lot of environmental studies has been done, but not the BLL. So I think once we have the results from this is going to create a lot of other outcomes, and I think a lot of other parameters has to be correlated, because no correlations has been done till now in India. I think the studies from the UK or the US, and these are creating a lot of examples for us that this is how the correlations can be studied from that perspective, from Indian perspectives particularly.
Anything to add?
No, that's it.
Great. All right, let's start at the back. Is there someone, I think I see a hand up right there with a red scarf on.
Thank you. I'm Jasmine Sultana from ICDDRB Bangladesh. So I have one question for Julian and also others, like if you can answer.
Can you put it a little bit closer to your mouth,
Sorry,
please?
can you hear me clearly?
Now better.
Okay. So my question is that developing a therapeutic for lead pollution is really, really important. And from HOPO, we have seen that it's really promising. My concern is that if we have a very effective treatment, then will that give the polluters a green light to continue the pollution and say, okay, there is already an effective treatment, but I can continue polluting. So how we can stop that to stop the polluters to pollute, because early years, it's neurological. We know that neurological effects are irreversible. So how we can put ourselves forward to stop the polluters to polluting, though we'll develop a very effective treatment strategy. Thank you.
Great.
Public health is first, I am going to say that.
Okay, let's take some more, please. And Theo, I don't know if there's anyone behind you? Or there's someone just next to you, basically.
E from Vital Strategy. I have two questions. One is for our Indian colleagues. I noticed that you're measuring IQ with WISC, and then it seems like you're doing a newborn, pregnant women study. So is this a cohort? Sorry if I missed that. When are you measuring the IQ point in your children? And then one is actually for Anna. This is very interesting to see the sex differences in the blood level in adults. We don't always find that in children. So I was wondering whether you can explain a little bit about that sex differences in adults and what you think behind if there is significant or not always significant differences between boys and girls.
Can I just take one more in the middle on the left? Yes, please.
Yeah, I'm a pediatrician. My name is Stefan Böse O'Reilly from Munich, from the university. The WHO guidelines for treatment exclude pregnant women with DMSA. And the question to Julian is, of course, when you tested the animal models, and you have former tests as well, what's the effect on pregnant mice? And why do I ask? Because the IQ, as E was questioning as well, the IQ is mainly developed before you give birth. And after birth, it continues to develop. But when you start schooling, you need the IQ to put on. So the IQ is not developed in school. Unfortunately, mine is declined because I'm already so old. So if you have these animal models, if you sacrifice the mice, and I know the amount of lead in the brain is not exactly what we need to know. We would need to know at membrane levels and all of this. But the MSA is really excreting the lead from the blood. But what we really need is some new therapy to protect the brain. And of course, the brain is protected, that medication does not enter the brain. So my question is, can you expand a little bit outside, or is this still closed and you should not talk about this? Because the question is there any medication that is entering the brain, reducing the blood levels in brain, and could you see any effect before and after treatment or between a group being treated or not? It's a very technical question, but for a pediatrician, this is more important than all this cardiovascular disease at the end of the life. But thank you very much for a very good session, and I enjoyed all presentations, but I only have a question for one of you.
Thank you. But maybe there's two questions in there. There's one about treating brain, and there's also, are we developing therapies for pregnant women, right? And do we have the ethics and the science and the regulations around that right? Yeah. Okay, there's lots of questions there. You can pick up what you want, Hannah, but I guess one to you particularly was around, I think, the gender difference, I think, was it?
That was in children, we don't see them.
Yes.
One of the reasons could be that the exposure could be more different in adults than in childhood. But also, I think women have menstruation with menarche, starting in menarche, so that's going to be a way of eliminating a little bit of lead each month. The other thing is that, and we know that women start liberating more lead into the blood during menopause. So those phenomena, those hormonal phenomena might be playing a role quite important. And actually pregnancies too. The more pregnancies a woman has, the lower the blood lead levels, because there is a transfer to the fetus. So all of these are reasons potentially. And in childhood, you don't have those reasons yet. But I believe there are many other reasons too.
Jyoti, you pick up what you like, but there was one about the IQ.
Yes. So particularly there's a limitation to this, because when we're testing from the 0 to 5 age group, we're not doing the intelligence and the cognitive for them, because they're the smaller children, cannot answer the WISC-4 software questions. So we're doing it for the 6 to 18, that is the 100 parameters, so we're doing the cognitive and the intelligence testing for them.
Julian, you had a couple of difficult ones.
Yeah, I'll start by kind of speaking a little bit to what Anna said at the end there with respect to mobilizing lead during pregnancy. I think this is a known phenomenon that the lead that is stored in the skeleton is mobilized during pregnancy. And Stefan's question about, can we think about an intervention to prevent transmission of lead from a mother to a developing fetus? To be completely honest, this would be a dream outcome for us. I mean, I think the opportunity to have such a meaningful impact on the next generation would be a really, really outstanding outcome. The development of an animal model to assess this would be quite challenging, to be honest. I think, we do have some work planned to try and do this, but you're talking about developing a disease model in a kind of embryo-fetal development that's different from the typical safety toxicology package that we would ordinarily do. So, I mean, as part of our drug development program, we have reproductive toxicology studies that would be required by, under the ICH guidelines, whether that's for the FDA or the EMEA or basically any regulatory body. So those are without a doubt planned. They have not been done yet. Everything that we've seen thus far about the metabolism of the drug, which is virtually zero metabolism, I think that I'm feeling as confident as I could be that we're not going to see any meaningful findings in terms of repro tox. That study that you kind of alluded to about, can we actually design an animal model where we can assess whether or not we can prevent transmission and ultimately or prevent accumulation of lead in the brain. This is a challenging study, in all honesty. It's a very challenging study. I think one of the key questions will be, is this required? can we use blood lead as a biomarker rather than lead in the brain, and ultimately a cognitive endpoint, which would involve a much, much higher powered study. So efforts like cord blood collection, I think, are really important for us in that regard.
I would like to add an innovation in that area. Some investigators are measuring extracellular vesicles derived from the brain, and we can actually measure the lead in those extracellular vesicles. And the levels are different from the ones that you would measure in blood overall. And so that could become a surrogate marker of brain lead levels. So there is kind of a lot of exciting innovation going on in that area.
We're nearly at the end of time, but Rebecca, I wanted to put a couple of questions to you. One, it comes back to a main point. I think it was 58% or something uptake of the intervention, right? And there's two things in my mind. One is, how can we improve that? Because that seems a massively important step. And then secondly, is there an issue with, I guess, maybe it's a slightly different question. Is there an issue with the control group that some of those might have accessed private support, or in some way contaminated your control group by accessing the intervention? So there's one part which is you don't get full uptake in the active arm, but then there's the idea that you might get uptake or private uptake of support in the control group. Did you have a chance to look at that?
Yeah. Can everyone hear me without a microphone? Good.
Yes.
Okay. So to address your first question about compliance, I think it probably comes down to outreach. That would be my guess, is that there's a significant level of distrust at the thought of having someone from the government. There's probably a significant level of distrust when it comes to families allowing someone from the government to come into their home, especially considering that perhaps some of these families are undocumented. So I think that one potential pathway would be maybe having a conversation with the pediatrician in the doctor's office about what to expect, and advocating for this program. I also think that there are additional potential pathways to increase compliance in terms of landlord requirements. So many of these families live in apartments and they have a landlord and they're renters. And so I think that the landlord needs to be notified that these remediations need to take place and that a child has been identified as being lead exposed. Those would be my main two recommendations to increase compliance with this intervention. The second question that you had was about whether or not the control group potentially accessed some kind of cooperative intervention. There are actually a very small number, around 30 or so, maybe less, out of the 5,600 families that didn't quite meet the eligibility criteria. And they still had access to the intervention. This is a very small percent of the sample that maybe they were so close and the doctor really advocated for the family to get this intervention, and so they did, despite the fact that they were not quite eligible. That being said, if the family had received this intervention, we would see that in the data. Regardless of whether or not they were ineligible, we would know if they received the intervention. That being said, it certainly is possible that the control group, in a conversation with the doctor's office, had this notification that their child had an elevated blood lead level, and then the parents perhaps took it upon themselves to say, well, our home was built in the 1960s, let's repaint the lead. But the families who were eligible but didn't take up the intervention likely could have also done the same thing. So I wouldn't think that there are any differences between the control group and the treatment groups, the treatment eligible group that did not take it up, and yet we still see these differences in the eligible group and the not eligible group. And I would think that those are the only things that would change, is whether or not you're eligible for the treatment. Additionally, if the control group had accessed these, let's call it substitute interventions, where they had repainted the home themselves or something of that nature, that would actually bias our estimates downward, And so our causal effect of a 5 percentile point increase in your test scores would actually be, in that case, considered extremely conservative, and the actual effect of the policy would be even higher if that were happening.
Excellent. That makes a lot of sense. So I'm afraid, I know there's lots more questions, but they'll have to wait until tomorrow or the discussion after this. I want to pass a huge thank you to the panel. That's a really inspiring session. And Lee, do you want to give any last remarks?
I won't keep you all. Thanks very much to all of our speakers and moderators today. I think it's been really excellent. We have drinks just outside, and we're kicking off at 9:15 tomorrow morning, so don't drink too much. Thank you, everyone.